Good morning and welcome to the Healthcare Affordability Board meeting. I will call the meeting to order, and please note that this meeting is being recorded. I'll ask now for a roll call.
Excuse us. Good morning, Dr. Sandra Hernandez.
Good morning, President.
Secretary Kim Johnson.
Present.
Richard Cronick.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Dr. Richard Pan. Don Molds. 5 present, 2 absent.
Okay, and that will establish a quorum, and I'll turn it over to Director Landsberg to go over our agenda today.
Thank you very much, Madam Chair. Good morning, everyone. On today's agenda are 2 action items that require a board vote. The first is to establish a standing subcommittee for the selection of a new advisory committee member to replace a member who resigned from their position in the health plan category. The second is a potential vote to approve the data submission enforcement penalty scope and range. And if the board does not vote on that item today, the item will be placed on December's agenda. Also on the agenda is a closed session for board members to discuss the lawsuit brought by the California Hospital Association against OCA. We expect to stop the public portion of our meeting for a closed session at approximately 11 a.m., followed by a public comment period, and then break for a half-an-hour lunch. Depending on where we are in terms of timing, we may move the discussion of the update on the cost and market impact review program up in the agenda and hear that item in the morning. And then after lunch, we will have a presentation of the Monterey Hospital Market Competition Study, followed by an introduction to the Data Submission Guide 3.0 regulations. Exciting topics, very important to us, including an update on the behavioral health definition and a summary of public comments and advisory committee feedback. And then if we didn't cover the CMIR update in the morning, then we will do it in the afternoon. And I'll just move, Secretary, to my executive updates. And my only update this month is about California's Rural Health Transformation application. So as you know, and as I talked about at the last meeting, the Rural Health Transformation Program is the 5-year, $50 billion initiative established under H.R. 1 for states to strengthen healthcare in rural communities. And I think we're all aware of the access and workforce shortages and infrastructure gaps in rural communities that create unique challenges. I'm very proud of the team at HCI that worked to submit that Rural Health Transformation Program grant application on behalf of California to the Centers for Medicare and Medicaid Services on November 4th. So this was a very short time frame, as I talked about last time. CMS released the Notice of Funding Opportunity on September 15th, giving us less than 2 months to conduct extensive stakeholder and partner engagement, and then to put together our application, which we submitted on November 4th. So again, this pictorial shows a summary of the 3 initiatives that California submitted. First is the transformative care model, focusing on improving local access to comprehensive evidence-based care through regional hub and spoke networks that focus on primary care and maternal health access. This includes developing and expanding telehealth access, e-consults, and other digital tools to ensure, we hope to strengthen financial stability for rural hospitals that serve as a key component in this initiative. We heard overwhelmingly also about the need to continue to develop workforce. So our workforce development initiative seeks to strengthen the pipeline of future health workforce in rural communities, develops a rural workforce mapping and planning tool, and expands existing training pathways, as well as creating new pathways for students and existing providers to train, upskill, and pursue health professions in rural communities, and build regional collaborations for rural recruitment and retention through incentives and wraparound supports for the rural workforce. And then last, but we think importantly to fill out this interconnected set of initiatives, is our technology and tools initiative to support the technical infrastructure of rural facilities through the enhancement of existing technology, modernizing current technologies such as electronic health records, screening tools, telehealth platforms, and developing a technical assistance center to provide support to facilities in modernizing their IT infrastructure. So again, we've submitted our application as a state to CMS. Under the statute, CMS is required by December 31st to inform states of the amount of funding. And then at that point, we would see what changes need to be made. So again, we've been pleased to have the opportunity to work on this initiative. Actually, yesterday, I and a couple of other HCI deputies were at a rural hospital, at a critical access hospital. It's always very sobering and impressive, their ingenuity. For example, this rural hospital put together a collaborative with 4 others to have a rotating MRI machine go to different hospitals on different days because they couldn't afford one. Just a lot of innovations. The chief operating officer was born at the hospital, left for college and whatnot, and came back. And so just the need to really develop workforce in the community and the trust that we see in those communities. He said for a while we had a hard time paying our bills, and it was hard to go to the stores because I could see the people, the hardware store that we weren't paying. I have to see those folks in the community. So really committed to engaging and doing as much as we can with the funding that we're given. And then I'm asked to give you a friendly reminder to board staff and speakers to please speak into your microphones, though certainly those of us who have strained voices today will try to get you off the hook. And with that, I'll turn it over to Deputy Director Pagani.
Thank you, Director. So my first update will be regarding OCA's ongoing work on hospital spending measurement. So this isn't shown on the slide here, but as everyone will recall, OCA is using claims and encounters in the healthcare payments database to calculate outpatient visit intensity. So in the HPD, providers are identified by National Provider Identifiers, or NPIs, while the hospital annual financial disclosure reports identify hospitals using CMS certification numbers, or CCNs. To align HPD claims and encounters with facilities that submit hospital financial data to HCI, we've been working to develop a crosswalk that matches NPIs to CCNs. So this is an exercise that involves a lot of checking in terms of alignment between, there's different identifiers. I only mentioned 2, but there's also license numbers from the California Department of Public Health. There's also facility numbers if there's multiple facilities under a license. So it's a matter of reconciling all these different data sets that have different unique identifiers for hospitals, and being able to create a crosswalk where we have some fidelity in terms of identifying hospitals in the HPD and matching it with other identifiers. So earlier this month, we began sharing facility-specific crosswalks with several members of the hospital work group and seeking their feedback on the NPIs we identified to their facility and if it was accurate. And then we plan to, in early 2026, plan a more comprehensive NPI to CCN crosswalk so that all California hospitals have an opportunity to provide feedback. And then, so that's kind of an update on the crosswalk, but I also do want to mention that we also plan to have a discussion item on outpatient hospital spending measurement in the December board meeting. So I'll take us to my next update, which is the Employer Health Benefits Survey from the Kaiser Family Foundation. So this is their 2025 benchmark health benefits survey of private and non-federal public employers with 10 or more workers. Nationwide, employer-sponsored health insurance covers about 154 million people under the age of 65. The survey found that in 2025, family premiums for employer-sponsored insurance reached an average of almost $27,000, with employees contributing an average of $6,850 and employers paying the rest. For single coverage, the average annual premium is $9,325, with employees contributing an average of $1,440. Over the last year, the average single premium increased by 5%, and the average family premium increased by 6%. by comparison over the same period, wages, which is the figure on the right, wages grew 4% and inflation grew 2.7%. Next slide. So this slide shows changes for premiums over time from 1999 to 2025 for single coverage. And then when we look at it just for the last 5 years, single coverage, the average premium increased 24%, and the average family premium increased 26%. During the same 5-year period, workers' wages increased 28.6% and inflation 23.5%. The survey and report provide additional detail about employer health benefits, breaking down information by employer size, plan type, cost sharing, primary care approaches, provider networks, and et cetera. Many large employers point to prescription drug prices as contributing to higher premiums, as well as coverage for new prescription drugs such as GLP-1s, the prevalence of chronic diseases, higher utilization of services, and hospital prices. Based on the average double-digit increases in the individual and small group market this year, many large employers are bracing for higher premiums next year, unless they find ways to offset high costs through changes to benefits, cost sharing, or plan design. And then I'll just take us to our standard reminder about the slide formatting. So yellow indicates informational items for board discussion, as well as the public, and decision items for OCA. Green indicates current or future action items for the board. So I'll turn it back over to the chair to facilitate discussion.
Thank you very much. And I just want to take a moment in appreciation to Director Landsberg and the HCI team on the Rural Health Transformation Grant and seeking that input on a very fast timeline to get those resources, given what we know will be new challenges ahead with the implementation of HR1. It's a critical resource. So thank you for the work on that and really engaging communities and developing that application. Also sobering update there from you, Vishal, on the healthcare cost increase. I'll turn to the board for any comments or questions.
Thank you. Likewise, I want to express appreciation. It's just remarkable how much this department is doing in such challenging times. So thank you for your work on the rural health transformation. And this may go without saying, but the KFF survey is at the same time one of the most depressing surveys consistently, and the one I look forward to the most at this time of year. But just, to remind folks, even this doesn't express the full burden of the cost crisis, because this doesn't reflect the growing deductibles and out-of-pockets that have been such a key feature of employer-sponsored benefits over the last couple of decades. So the actual cost impact is even greater than these numbers show. And just to put a fine point on it, right, the $26,000 or $27,000 for a family premium in the context of household income is a shade over $80,000 right now. It's just, healthcare is at the center. It is the top of the affordability crisis in this country and in this state.
Thank you. I will now open up to public comment for any public comment on the executive updates.
We will now take public comment on this item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of public present in this room and those attending virtually. Those in the room may line up at the podium. Those attending virtually can raise your hand. Those dialing in can press *5. During the public comment period, you will be unmuted when it is your turn. We also invite you to provide written comment at the email address provided on today's posted agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda for today, except to place the matter on a future meeting agenda. I'll start with the individual at the podium.
Beth Capel for Health Access. We want to begin by both thanking the HCI for the work on the Rural Transformation Grant, and also to commend this board and this staff for taking early action to implement the cost targets, both at the statewide level for health plans and insurers and hospitals and large physician organizations, as well as the sector targets. We often sit through legislative hearings where departments are berated for being late on statutory deadlines, and it is a pleasure to acknowledge that the work of this board and this staff has resulted in you not only meeting your deadlines, but doing it early. And so we think that deserves commendation, not an attack. With respect to the KFF study, which I similarly find appallingly depressing, I would note that I bought my house in 1999. According to the neighborhood comps, it's worth 3 times as much as when I bought it. Reasons having nothing to do with what I've done to spiff the place up. These premiums are 5 times as high. We all know that housing affordability is a crisis in California. Healthcare affordability is too, and that's why we're here doing the work we're doing. And I would second what Board Member Lewis said. You earlier had a presentation a year or 2 ago now, my gosh, that previously only 30% of California families had deductibles with their job-based coverage, and now it's 80%. They're more prevalent and they're much bigger. So I appreciate the staff bringing current studies to us and commend them for that. It is indeed worse than it even appears. Thank you.
Thank you. Looking virtually, seeing no hands raised, looking back to the podium, seeing no one at the podium, that concludes public comment on this item.
Thank you very much. We will move on to item 3. This is our consent item. I'll turn it over to Deputy Director Brigatti.
We have the meeting minutes for October. They've been distributed along with written public comment received since the last meeting.
Is there a motion to approve?
So moved.
Second.
Okay, and we'll now invite any public comment on this item, October 28th minutes.
We'll now take public comment on this item. Please step to the podium or raise your hand virtually. Seeing no hands raised virtually and no one stepping to the podium, that concludes public comment on this item.
Okay, and I'll call for the vote.
Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson.
Aye.
Richard Cronick.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan. 5 ayes. The motion passes.
And the motion passes. Thank you. We will move to item 4. Next, we have a vote to establish a 2-year standing subcommittee for the selection of advisory committee members, including to fill the current vacancy. I'll turn it over to Megan Brubaker to present this item.
Thank you, and good morning. Go to the next slide. So OCA recently reopened the Healthcare Affordability Advisory Committee application submission process to fill 1 vacancy. We are seeking individuals with the healthcare payer perspective. The deadline is November 30th, so there's still some time for anybody interested. And the term would be from January 1st, 2026 to June 30th, 2026. And the selected member may apply for reappointment thereafter. Go to the next slide. And as we can see, this vacancy is in our payer category. As we mentioned, I believe last month, Eliza Arjoin retired, so she will no longer be in this position. And go to the next slide. This is somewhat of a draft motion that needs to be filled in more, but before turning back to the chair to facilitate this discussion for the board, I would like to thank Elizabeth Mitchell and Richard Pan for serving on this committee for the past 3 years. And like I said, this is an example of a motion to appoint 2 board members to a standing subcommittee that will work with the staff to provide recommendations on advisory committee selection for the next 2 years. This would include working with staff to fill vacancies during the annual solicitation process for the next 2 years. And so we just need to fill out which 2 board members in that motion, if it is approved.
All right, and thank you again, Elizabeth and Dr. Pan, for their service in this capacity. Are there nominations for such a role?
It's perhaps not a accident that Elizabeth's on one side of the table and there are 3 other people on this side of the table. I would nominate my esteemed colleagues to the right, Ian Lewis and Sandra Hernandez. I think they would, I know that they would do an excellent job in picking advisory committee members.
Grudgingly, I will accept your nomination with appreciation for the outsized work that members Mitchell and Pan have done over the last few years. And thank you.
I'm happy to help work with staff.
We can figure out if Megan can sweeten the deal with cookies at these particular committee meetings or other incentives. And I'm happy to volunteer with, not just volunteer you, but also support.
Elizabeth, I do want to appreciate the tenure that you and Dr. Pan have served in this capacity. I think it's served our advisory committee well, so I just want to appreciate you on the record. Thank you.
Indeed. Here.
All right. So we have a motion then to appoint Ian and Sandra to fill the standing subcommittee that will work with staff, that will work on this advisory committee. Is there a motion? I think a motion. Bruce?
That is a motion. Yes.
And a second?
Second.
Okay. We'll take, I think, public comment on this item.
We'll now take public comment on this item. Please step to the podium or raise your hand if you're attending virtually. I'll give it a moment. Seeing no one stepping to the podium and seeing no hands raised virtually, that concludes public comment.
Okay, we're ready for the vote if you can call.
Dr. Sandra Hernandez.
Well, I'm willing to serve. I'm going to abstain on the motion.
Secretary Kim Johnson.
Aye.
Richard Kroenig.
Aye.
Ian Lewis.
I'll abstain.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan. We have 3 ayes and 2 abstain.
Great, motion passes. Thank you very much. Appreciate serving in that capacity. And again, thank you to Elizabeth and Richard. We'll move on to item 4B. This is the vote to approve the data submission enforcement penalty scope and range. I want to thank the team for continuing to work through this with the board on what's feasible here and what's in the best interest of what we are trying to accomplish. So with that, Deputy Director Bergani, I'll turn it over to you to present.
Thank you, Secretary Johnson. So we have an action item on the data submission enforcement penalty scope and range. Before I go over the action item, I will first provide a summary of board feedback from the October board meeting, followed by a reminder of prior advisory committee feedback, as well as written and verbal comment received. So this is the feedback from last month. Multiple board members raised concerns that the penalties are too low to incent compliance. A member recommended increasing the failure to submit data penalty in the months following December 1 rather than waiting a full year. Another member suggested doubling the penalty amount every 3 months after December 1. A member noted the lack of compliance with federal transparency reporting requirements and that many entities did not respond until the penalty, became so problematic that executives noticed. This serves as an example for OCA. Next slide. So continuing with feedback from last month, a member commented that a consequential upfront penalty and then going before an administrative law judge would incentivize timely data submission. A member requested that the office double check the penalty amounts as a percentage of a plan's annual net profits. I'll confirm that the data is correct and notes from last month, and that the $5 amount is per member, not per member per month. A member requested a better understanding of DMHC, or the Department of Managed Healthcare's experience with administrative actions, including what it means in practice to enforce the law through an administrative law judge, and we covered that last month. And then going on to advisory committee feedback. So this is from, I believe, the September advisory committee meeting. So we also presented these slides last month. Some advisory committee members expressed concern that the proposed penalty structure will not motivate healthcare entities to timely submit data, and larger health entities would potentially view the penalties as inconsequential and simply the cost of doing business. Another member suggested that instead of the two $10,000 penalties, so this is kind of an earlier draft that they were reacting to, increasing the penalty amounts to $10,000, $50,000, $100,000, or $250,000 based on the size of the entity. This could encourage entities to submit their data closer to the deadline. Another member appreciated that the fines multiply each year, making it so expensive for submitters that they have to comply. This reduces the incentive for submitters to skip a certain bad year because the fines would continue to multiply. A member commented that having public testimony to explain the reasons for non-compliance is valuable. And then now moving on to written feedback. So the slide only shows feedback that we received in writing, but then I'll also go over some public comments we received last week as well. So shown on the slide, a commenter requested a corrective action plan process before imposing penalties, increasing the data resubmission window, and exercising penalty discretion when entities demonstrate good faith efforts to comply. A commenter recommended having the penalty reflect the financial condition and size of the entity. In addition, a per member per year penalty for health plans insurers with similar scaling to size for other entities. The commenter also noted escalating penalties month by month from December until July or August of the reporting period, and then year by year until in year 3, making the penalty commensurate with the incentive to avoid data submission. Now I'll cover some comments we received specific to the data submission penalty after the slides were posted. A commentator noted in their comments a revision to their earlier proposal, which that scales up the penalty over 3 years to an amount commensurate with the estimate of the avoided penalty for exceeding the target in year 1. And then moving on to verbal public comment. So these were made at the last meeting in October. A commenter stated that the penalty proposal will not induce future data submission compliance, especially when a spending target enforcement penalty could be hundreds of millions of dollars in comparison to a small data submission penalty. They also recommended placing the penalty in the context of an entity's national revenues, which ranged from 100 billion to 300 billion, and stated that some larger entities routinely ignore California law. A different commenter expressed concern that the penalty proposal will not motivate entities to timely submit data, and recommended proportionate and escalating penalties scaled to an entity's size to ensure the penalty is a legal obligation and not just the cost of doing business. And then lastly, a commenter shared that health plans have been compliant with data submission requirements before any penalties are in place. Industry takes the requirements seriously and approaches the process in good faith as a partner. They appreciated OCA's recognition as it finalizes the penalty framework that data submission compliance has been consistent across the board. So next slide. So now I'll review the proposed data submission and enforcement process, and this is updated based on feedback we received from the board, as well as public comments and the advisory committee. So just to recap with everyone, data is due to the office on September 1. We have 2 optional extensions that allow data submitters more time to submit. Both have some requirements about keeping OCA updated with regular status updates. These have not changed. Next slide. Next, if data has not been submitted by the submission deadline or by the end of one or both extension periods, submitters would be subject to an initial flat untimely data submission penalty of $10,000. And we're calling this level 1 of the untimely data submission penalties. If data are not submitted by November 1, the submitter would be subject to an additional flat untimely data submission penalty of $50,000. This is an increase from the prior version of the proposal, which had the additional penalty of $10,000, and we're calling this level 2. Also on November 1, the progressive enforcement process begins with a notice that the entity has failed to submit data. The office would require a plan to submit data and provide technical assistance if needed. This moves the progressive enforcement process up from December in the prior version of the proposal. And the office still has the optional step of a public meeting and public testimony for submitters that have not yet submitted by November 1. So this slide features some changes from the proposal shown at last month's meeting. If data is not submitted by December 1 or the agreed upon date, that is no later than January 1, the entity would be subject to a $5 per member failure to submit penalty. In addition to the untimely data submission penalty, this moves the per member penalty up from January 1 in the prior version of this proposal. If data is not submitted by December 31st or the agreed upon date, the per member penalty would increase to $10 and would be assessed in addition to the the flat data submission penalties. And we're calling this level 3. The per member penalty amounts will double for each consecutive year that the office assesses an entity a failure to submit data penalty. So as you can see on the slide, year 2 for a submitter that fails to submit data, the submitter faces a $10 per member penalty on January 1st, or excuse me, on December 1st of the second year, and a $10 per member penalty on December 31st. And that goes up to $20 and $40 per member in year 3, and $40 and $80 per member in year 4. So taking us to one more slide, or a few more. OCA would continue to pursue other legal remedies. The penalties are not the only tool in our toolbox. The office could take administrative action and could notify the licensing or regulatory agency of the entity's failure to comply with California law. How this may play out is that a penalty would be imposed on an entity if it misses the due date. An administrative law judge would say that the fine must be paid and the data must be submitted within a certain time frame. Non-compliance could also result in a referral, as I mentioned, to the entity's licensing entity, which could affect its license status. It could also result in an action to enforce the penalty in the Superior Court and in order to pay interest. OCA will provide board updates on the compliance with data submission requirements annually, starting at September board meetings, and make public all penalties once formally assessed. So this next slide is just kind of a recap of what I covered in a more visual format. So you see here in September, it has the optional extensions. October has the $10,000 untimely data submission penalty and 30 additional days before further action. November has the $50,000 untimely data penalty 30 additional days before action. There's also a data submission requirement, a data submission plan requirement, possible technical assistance, and possible public testimony. And then taking us to December, so there's a $5 per member failure to submit data penalty and an additional 30 days before further action. So I'll note in January we have a typo. The second bullet was kind of a copy and paste from the prior month. I would just focus on the first bullet. So January has a $10 per member failure to submit data penalty. So it's really from January because they have until December 31st to submit the data before the $10 per member penalty is imposed. So it's really effectively in January we could begin compelling data submission through legal action. And then the next slide before we break for board discussion is we have a draft motion here which effectively lays out what I covered in the prior slides.
Thank you very much, Deputy Director. And again, appreciate reminding us of kind of the journey along the way in terms of the input that we've had at the board level and also at the advisory committee to craft this latest version. Elizabeth.
Thank you. If this is what the staff want to do, I can support it, but it seems really administratively complex and burdensome and basically gives everyone 6 months to comply. So before some enforcement is taken, is that, I mean, is there like a way to simplify this and just skip this graduating approach?
Yeah, if it looks like 6 months, I think the February wasn't meant to be on that last slide I showed. Effectively, the last day before the $10 per member penalty occurs would be December 31st. So it's really a 4-month process between September 1st being the due date. But there's a few cliffs. The $5 per member penalty would be December 1st, which would be significant, and then it essentially escalates in January if we don't get compliance.
Yeah, I understand that. I'm just suggesting maybe we collapse this into maximum of a 3-month process and just, skip some of the graduating steps. It just seems like a lot to manage for staff because there's a lot of plans, there's a lot of steps, a lot of options, a lot of graduating penalties.
Thanks very much. I mean, I think we appreciate always the attentiveness to what it would take to do. I mean, again, as we've all noted, we hope that this won't come to pass frequently, so I don't think it will be a significant number of times. We're trying to balance, absolutely we're in agreement that we need the data, and we also know that sometimes there are technical challenges that the plans may face. And so I think it's not overly administratively burdensome for us to issue a penalty and then there's sort of one collection effort if they're not paid. So we think this is feasible, and obviously it's the board's discretion.
Yeah, I'd really love to see an update about how many plans just end up waiting till January, or like how this ends up going.
Yes. So I think as we've noted, am I correct? We have 50 of 50 that have submitted, or 48 of?
48 have submitted, and then 2 are just kind of we're reconciling a few issues.
Yeah. So absolutely, we will keep the board updated every year about the data submission progress.
Rick?
Thank you. Yeah, I was going to ask the same question, so thank you for answering that. Thank you for your work on this, and I think, thinking about the discussion we had last month, these penalties are still not going to be big enough in and of themselves to make or get compliance if a plan is seeing it as in their financial interest to not comply, right? These are still kind of less than, a tenth of 1% of premium revenue, even at the $10 a month. Maybe at $10 a month is about a tenth of 1%. Having said that, given the experience to date where all plans are complying, and as was mentioned last month, that might change when there is a bigger financial incentive to not comply. I'm still happy to go along with quite small penalties at this point, and mostly relying on good faith that plans are going to want to do this. And if we get to a situation in some number of years where there are one or more plans that seem purposely, trying to not provide the data, then we might want to revisit this and increase the penalties at that point. I can see the argument for starting with something large enough to try to avoid that, but I'm on balance, starting with a relatively light penalty structure and relying on good faith makes sense to me.
Sandra.
Well, let me appreciate staff sort of threading the needle between advisory committee feedback, public comment, and the various feedback you got from the board. I appreciate that the penalties got accelerated in time, because I think that was a big issue about really wanting to get the data on a timely basis. I don't think it's the only tool in the toolbox, and I appreciate that you noted the administrative avenues that we have as well, in addition to the penalties, which are modest. And I think we should acknowledge that thus far the plans have largely complied, and I suspect we'll want to be able to do that to be a good standing member in our ecosystem of plans. So I'm willing to support this with the caveat that it isn't the only tool in the toolbox, and that we would revisit it were we to see that there are significant financial incentives that are having folks not want to comply with data submission. So thank you to the team for trying to thread the needle there.
Thank you, Ian.
Yeah, I'll echo the skepticism that this by itself is sufficiently deterrent, but I do very much respect the direction from staff that this is what you need to be effective. I just only add that given the repercussions of not getting any data, my expectation would be 100% deterrence against any games here. And if we fall anywhere short of that, I will be the first person advocating to raise these so they truly are deterrent.
Thank you. I think we are going to take a motion. Have a motion then which will be approving what's appearing on slide 28. Our motion.
Also move.
Second.
Okay. And then we are going to take public comment.
We'll now take public comment on this item. Please step to the podium, or please raise your hand if you're attending virtually. Please limit your comments to this item and to 2 minutes. Looking to the podium, go ahead.
Beth Capel with Health Access. Health Access appreciates the staff proposal that includes accelerated and somewhat increased penalties. We continue to think that $5 and $10 is not enough when we are facing a situation in which the financial incentives to fail to submit data could be very substantial. We provided in our letter examples of large insurers and health plans ignoring California law because of insufficient penalties by other departments. And I'm sorry to say that includes both plans domiciled here in California and those domiciled with most of their business in other states. I checked because sometimes I feel like the large national plans that don't have much business here act like California doesn't matter. But it's both. Missing the growth target by several percent could easily involve billions in costs in excess of the target. And we're talking about here a penalty of $5 or $10. So we are pleased that the plans have thus far been compliant, but we're also not dealing with an enforceable target as yet. We have consulted with former insurance commissioners in other states and other states involved in enforcement of cost growth, our counterparts in other states involved with cost growth targets. And data is often submitted, but it's not complete, it's not accurate, it's not usable, it's not, it doesn't pass the standard test of being reasonable. So we recognize that at the moment this wouldn't get used, which is good. We are troubled about what the implications are for the future. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Hi, good morning. Kei Yamamoto with the California Pan-Ethnic Health Network. We'd like to echo what our colleague at Health Access just said and reiterate that $5 per person is not enough to make insurers with hundreds of billions of dollars in revenue submit data on time. The fines should be strong enough to make them take timely data submissions seriously. Late or incomplete data is going to hurt us as consumers. And this is the information that tells us if California is meeting its healthcare affordability goals. Consumers and small business owners are the ones who are going to pay the price if data is missing and is not submitted on time. Thank you.
Thank you. Looking back virtually, seeing no hands raised, back to the podium.
Madam Chair, members, Sarah Flocks. I'm here from the California Federation of Labor Unions. We represent 2.3 million union members in the state of California, along with a number of labor management trust funds that are self-insured and purchase health coverage. So we know how important data is to unlock why the price of healthcare is so high. It is also key to this board's work to keep health coverage and healthcare affordable in the state of California. So we know this data is basically the foundation of the work that you're doing. And we will have to echo the previous speakers. These penalties are woefully insufficient. It is fantastic that there is so much compliance now, but we want to have a very strong upfront penalty to make sure that compliance continues and you don't have to go to escalating penalties or a long process, a 6-month process of getting this data. If there are not strong penalties for data, how do we expect these entities to have any compliance for meeting the hard part, which is the basically bending the cost curve? And so this entity needs to come out strong and show that you will enforce what you were charged to do. And if players in the healthcare industry are not going to comply, this board will make sure that they comply and that it is not just the cost of doing business. We have a lot of experience in labor law enforcement. This huge growth of an underground economy is because pay the penalties. It doesn't matter. The risk, it's just the cost of doing business. We cannot let this board establish that. It is too important. So we urge that there is consideration of strong penalties, but I thank you all for the incredible work you're doing. I don't get here to say it enough. But that's why we're urging you to come on strong, because your work is so important. Thank you.
Thank you. Looking virtually, seeing no hands raised, noting for the record we have about 100 virtual attendees at this point. Seeing no one at the podium, that concludes public comment on this item.
Thank you very much. And I just want to again appreciate, and this was lifted up in some of the comments from my fellow board members here, that it is the penalties in combination with the other remedies that we'll have and OCA will have at their disposal, including legal action, et cetera. So just want to make sure we're looking at it in totality as we go along too. If we could call for the vote.
Now for the vote, Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson,
Aye.
Richard Kronik,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Dr. Richard Pan. 5 ayes, 1 absent.
And the motion passes. Thank you very much. And again, thank you for the continued work on that item. We're going to move to item 6C, given that we have a little more time here. This is the update on cost and market impact review program. And I will turn that over to Sheila.
You don't get seasick while they advance the slides. All right, good morning. I'll introduce myself again so that those attending virtually can hear my name and say hello to everyone in the room. I'm Sheila Tatayan, and I am the Assistant Deputy Director for the Compliance Branch of OCA and also the Chief Counsel of OCA. So we had put together, a review and an update for you, as we've tried to do quarterly from the outset of our program. So if you could advance the slide. So the big news is that AB 1415 passed, and this expands OCA's jurisdiction. Now private equity groups and hedge funds will be required submitters who will have to file notice of a material change for transactions involving healthcare entities. Management service organizations, MSOs, will also be required submitters. And the last bullet point takes a little bit of explanation. Entities that own, operate, or control a provider, regardless of whether the provider is currently operating, providing healthcare service, or has a pending or suspended license, will also have to notify the office. Now, this was probably a little bit confusing to some during the legislative process, but in our experience, what we saw happening was that entities that may have wanted to purchase a health entity that wasn't currently operating would try to evade OCA's jurisdictions by claiming they're not a healthcare entity. And to some extent, it was true. If they weren't providing healthcare services, they weren't considered a healthcare entity. So this was really addressed to capture that kind of gap that was unintentionally resulting from situations where, let's say somebody already owned some facilities, wanted to own another, but yet they'd had pending licenses. We might not get notice of that transaction. And there's also other examples, but this does aim to capture some of the system acquisitions as well. The statutory amendments also define specifically what private equity groups are, hedge funds, and the first time a definition of MSOs is in any healthcare statute, to my knowledge. So, and another important fact is that OCA will now be able to collect data directly from management service organizations. All right. So now let's move to the next slide. So we will need to promulgate and implement regulations on that. And so this slide shows you the timeline. We are in November now. We hope to have possibly a few stakeholder meetings. We'd like to do some one-on-ones to get input from MSOs, from associations, from private equity. So we'll be doing those in November and December. And then we would be presenting preliminary text to the advisory committee because there's an advisory committee meeting in January before the board meeting. And then we will be doing a public workshop as we have done before with our regulation language. And then we would be coming back in February for board discussion. And our plan, which this is an aggressive timeline, our plan is to submit to the Office of Administrative Law so that the regulations can become effective in spring of 2026, so we can start receiving those material change notices of these transactions. Okay, next slide. So these next few slides are really a recap of what's on our website. I won't read them all, but if you have questions about any of these transactions, you can go to our website, and it's designed so if you click on the name of the entity, it will pull up the notice that was filed by the entity and the other entities in the transaction, if there were more than one filing. So these are the ones that are currently in review. We'll go to and you notice on the note at the end that there were 4 additional, let's go back to the slide, 4 additional transactions in review, but those we have to determine whether the submissions were complete before we post them on the website. So what happens is we will get a notice through our portal. We have to review it first to determine that the submitters have complied and included everything that's required under the regulations. Once we determine it's complete, it then goes onto our website, and then we start counting the time period for our preliminary 45-day review to determine whether a waiver will be issued. If not, in 60 days, we would tell them whether a CMIR is required. All right, we can go to the next slide. Again, I won't read all of these. You can look at them on our website. I will say that the last one, the ambulatory Topco, we actually issued a waiver in that transaction just before these slides went to print. I do want to point out something that's not in the slides about the number of transactions, because we've talked about that before, and we've always been comparing to other states. So far in 2025, we've received 26 transaction notices. So that's 26 total transactions. We may have received actual notices that number more than 26, but that's because there may be multiple parties filing for a single transaction. So 26 transactions so far compared to the 15 that we received in 2024. But remember, in 2024, we didn't start until April. We think we'll be getting more in these next few months. Last year seemed to be a little bit heavy in December in terms of receiving notices. So comparing this to Massachusetts, Massachusetts has been receiving notices since 2013, and they have reviewed 193, what they call market change notices, in that 12-year time period. Of those 193, they have sent 11 to a full cost and market impact review, which is approximately 6%. So averaging the amount of notices they receive over that 12-year period, it averages about 16 per year. Now, Oregon has a more recent program, and they started in March of 2022, and they have received 49 transaction notices. Of the 49, they have sent 6 to what they call comprehensive review, which is very similar to our cost and market impact review. So that's a greater percentage of transactions going to a full review. But remember, Oregon has the ability to stop a transaction. Both Massachusetts and California do not have the ability to stop a transaction. So the average for Oregon per year is also about 16 per year. So you can see that those states right now are kind of running at the same kind of average, 16 transaction notices per year. So looks like we're going to be higher since we're already at 26 this year. All right. So this slide, going back to the slides, you may remember that our first transaction that we ordered to a cost and market impact review was Covenant Care. It involved the acquisition of 22 skilled nursing facilities, but the cost and market impact review focuses on just 3 of the facilities being acquired, and that is still in review. We're awaiting information from a third party, and so when we await information, we stop the clock. And so, the message there is, if you are in the middle of a transaction, you want to see your transaction progress through the review, timely provide the information, because when we don't have all the information that we need, just like the federal government, the FTC and the DOJ, we stop the clock. So just like they do in their Hart-Scott-Rodino HSR reviews. And then another current transaction review is ResCare. This is the acquisition of facilities that treat individuals with intellectual and developmental disabilities. Okay, and then next slide. And this was a hospital transaction. And these first few slides that we went over, these are the transactions that we have received since May, because the last update we gave you was in April. So today I'm just talking about the ones and showing you the ones that we've received since May. And then the next slides show which ones have been waived. And as I said, I'll repeat again, our website has a whole bunch of information. You can see frequently asked questions. You can see the decision tree for submitters. If they're not sure if they have to file, our decision tree walks them through a yes/no response and hopefully guides them to whether or not they have to file. And again, if you want to see any details on the notices, just go to our website and click on the name of the party. Are there any questions?
Thank you for that update. Questions from the board? Okay, not seeing any public comment.
We'll now take public comment on this item. Please step to the podium or please raise your hand. Seeing one hand raised right now, we'll go ahead and go virtually. Matthew, you should be unmuted on our end. Please go ahead. You've got 2 minutes.
Hi there. My name is Matthew Lynn. I'm an attorney with Bolsonelli. We have a lot of clients with material change transaction notices. And one question that has come up is whether the private equity companies, hedge funds, and MSOs that are added under AB 1415 will have to provide notice and what kind of information they'll have to provide before the implementing regulations are adopted. So any clarification there would be appreciated.
Thank you. The comment is noted. Going to the podium.
Beth Capel, Health Access, just to reflect that when you were adopting these regulations, which were, as I recall, controversial at the time, you were told that there would be thousands and thousands of transactions subject to it. And even though California has somewhat, being a larger state, has somewhat more transactions than Massachusetts or Oregon, it's certainly not thousands and thousands of transactions a year. So we're pleased to see that this is working as intended. Thank you.
Thank you. Looking back virtually, seeing no hands raised and seeing no one else at the podium, that concludes public comment on this item.
Thank you very much. We are going to move to item 6B. This is the introduction to DSG 3.0 regulations, including update on behavioral health definition and summary of public comments and advisory feedback. This will be presented by Andrew Fair, Research and Analysis Group Manager, Margaret. Oh, no, not Andrew. Okay, the Deputy Director of Agani, Margaretta, as well as Debbie. Turn it over to you. Thank you.
Sorry about that. So I'll be covering this item and then turning it over to Margaretta and Debbie. So taking us to the next slide. So the Data Submission Guide 3.0 outlines requirements for submission of data for the 2024 to 2025 calendar years, and this data will be due in 2026, September 1st to be specific. So we plan to have a draft of the revisions to share for public comment in January 2026. And then, as we've mentioned before, there's an annual registration cycle where submitters need to register on the OnPoint system. So that would be due May 29th of 2026. And then taking us to the next slide. So some of the key changes for DSG 3.0 will be the new behavioral health file, including payment allocation instructions. And then Margaret and Debbie will go into a lot more detail on how we're defining behavioral health, and it'll be more clear what we mean by payment allocation instructions. So Medi-Cal data will be required in all files. So right now, Medi-Cal managed care plans submit the APM and primary care files. And we've been relying on medical loss ratio data from DHCS for the total medical expense information. So we're proposing to require Medi-Cal MCOs to submit all files, including the spending files. There's some new instructions for separate reporting of self-insured member months and spending in the statewide total medical expense file only. So some of the thinking pertaining to that change is OCA relies on the MLR filings to calculate health plan administrative costs and profits for fully insured lines of business. To keep it cleaner, we need a way to align fully insured total medical expense in the statewide file with the MLR data we get from DMHC or the state regulators. And then copies, we're also requesting this fourth bullet here, copies of the medical loss ratios reported, or we would ask that the carriers email these to OCA or submit them via the portal. So there's a timing issue in terms of the submitters submit these files to the federal government, specifically to SSIO or the Center for Consumer Information and Insurance Oversight. So we don't actually get the MLR data until quite later in the year. I think last year we got it in December. We'd like to be able to get it sooner. If the plans submit what they send to the federal government directly to us, essentially a copy of what they submit, and then we'll later reconcile if there's any updates along the way. This will allow us to calculate admin costs and profits sooner, and then maybe be in a position to preview, since we do payer previews in terms of going over data with plans on what they submitted to us. We could also at some point include a preview of the calculations for admin costs and profits sooner. So that's some of the key changes. And then on the next slide, I'll turn it over to Margaretta to cover the changes for APMs and primary care.
Good morning. Thanks, Vishal. So again, Margaretta Brandt, Assistant Deputy Director for Health System Performance. So these next two slides provide some details on the proposed changes in the Data Submission Guide version 3.0 for the alternative payment model or APM file and the primary care file. And these proposed changes are based on our experience of the first round of data collection. And we've made several updates to clarify the instructions for these two files. So for the alternative payment model file, we are revising language in several places for clarity. So for example, we've provided additional guidance on how member months are attributed based on member months of coverage. And also in the APM file, we have revised this section includes step-by-step instructions on expense and member month categorization and a new process map illustrating how to perform this categorization for completing the APM file. And then for the primary care file, we've revised language in several places, again, to improve clarity of the instructions, including clarifying primary care spending attribution methodology for non-claims payment subcategories, such as practice transformation and capitation payments. And then we also revised language to clarify that primary care spend for claims-based payments are reported at the claim line level, not just the claim level. And again, there are several updates that we have made to the primary care code set just based on refreshing the code set to account for any changes. So for example, based on stakeholder feedback, we've added an additional physician assistant taxonomy to our primary care provider list. And then we've also added new advanced primary care management service codes that were released by the Center for Medicare and Medicaid Services, or CMS. So the new primary care code set will incorporate those new codes. And then on the next slide, we have some proposed changes that we're making specifically for Medi-Cal managed care plans only. So in collaboration with DHCS and in response to feedback and questions from the managed care plans, the MCOs, we have added reporting requirements that clarify which payments to include or exclude from the measurement of primary care spending the numerator and denominator for primary care spending, and also for alternative payment model, data collection. So for example, pass-through payments will be excluded, and whereas another example, vaccine administration fees from the Vaccines for Children program will be included. And this guidance has been developed very closely with DHCS. And also in the primary care file for Medi-Cal managed care plans, we've revised the methodology for the claims payments to instruct managed care plans to use what's called a monthly 274 file submitted to DHCS in their annual network certification to determine whether a physician, nurse practitioner, or physician assistant listed as the rendering provider on the claim is designated as a primary care provider in that plan's network. So this requirement is analogous to the requirement for commercial plans to use their annual network files submitted to DMHC to determine which providers should be considered primary care providers. So those are the proposed clarifications to those two files, and specifically, especially for the Medi-Cal managed care plans. On the next slide, we'll refresh the timeline. So following the same timeline as last year, in January, OCA plans to publish the draft regulations for public comment and present updates to both the advisory committee and the board on the data submission guide. And then following revisions based on feedback received through public comment, the data submission guide 3.0 will be submitted to the Office of Administrative Law in approximately March, and then will become effective in April. Submitters will register with OCA in May of 2026, and data submissions will be due on the first business day of September 2026. So that's a brief update on those overall, the data submission guide and the APM and primary care files. And next we'll turn to our new addition to the data submission guide, which is the behavioral health definition. And we'll also share the summary of public comment that we've received on the behavioral health definition and advisory committee feedback. And so Debbie and I will present both of these. I'll turn it over to Debbie in a bit to summarize the public comments and the advisory committee feedback. So just as we usually do, starting with a reminder of our statute. So we have two related activities for behavioral health spending. So first, we're required to measure behavioral health spending as a portion of total healthcare expenditures. And second, we're required to set a benchmark for behavioral health spending. If we can move to the next slide. Another reminder, this is the equation that we use to guide our behavioral health spending measurement, which is the numerator here. And OCA statute requires us to measure behavioral health spending as a percent of total medical expense, which is the denominator. So both the numerator and the denominator include claims and non-claims payments. And we have specifications for both, as measuring them is different. And also of note, the numerator will include pharmacy spend for behavioral health medications and also patient out-of-pocket responsibility for behavioral health services obtained through the plan. And the denominator will include all pharmacy spending and all patient out-of-pocket responsibility. And on the next slide, we wanted to share as our overarching structure, we have the numerator, denominator, and then within that numerator, we have three modules. So our behavioral health measurement methodology includes three modules of spending. So there's claims, non-claims, and then behavioral health and primary care, which includes both claims and non-claim spending, but will be measured distinctly. And this is the same structure that we used for measuring primary care spending. And on the next slide, we'll start with our behavioral health claims-based spending module. So these are the high-level principles on which our methodology is based. So first, all claims with a behavioral health diagnosis will be included in the measurement of behavioral health spending. And I'll specify further, all claims with a primary behavioral health diagnosis will be included in the measurement. And in addition, claims for screening or assessment of mental health or substance use disorder will be included in measurement regardless of whether that claim includes a primary behavioral health diagnosis. And next, behavioral health claims will be categorized based on place of service, revenue, and service codes. So the categories are relevant both for reporting purposes and for identifying spending that may be included in a potential future focused behavioral health investment benchmark. The other service category, other services category, is used for claims that meet the requirement of having a primary behavioral health diagnosis criterion, but do not have a combination of place of service, revenue, or service codes associated with any specific subcategory. And we'll talk about the subcategories of how we're categorizing behavioral health claim spending in a bit. And then finally, a set of national drug codes will determine whether a pharmacy claim should be included as either mental health or substance use disorder spending, independent of diagnosis. And on the next slide is our claims-based process map. So this is the process map that brings together the steps for identifying behavioral health claims. So starting with the blue box on the top left, the first step is to identify or determine whether the claim includes a primary behavioral health diagnosis as defined by OCA in our behavioral health code set. And then if the primary diagnosis field does not contain a behavioral health diagnosis code, the claim may still be considered for behavioral health if it includes a service code for mental health or substance use disorder screening or assessment. And that really, our intention here is to recognize that these screenings are incredibly important for prevention and population health regardless of a resulting diagnosis. So if one or more of those services are on the claim, then those lines of the claim are considered behavioral health. And then if we go back up to the first blue box and we move along, if the claim includes a primary behavioral health diagnosis code, then the next step is to categorize that claim by place of service, revenue, or service codes. And any claim that clears that first primary diagnosis hurdle will be considered a behavioral health claim, and this second step is to categorize them. And then our separately for pharmacy, the process, if a pharmacy claim includes a national drug code or NDC that OCA defines as a behavioral health treatment, then the claim is a behavioral health claim. Also want to note here that all claims will be categorized as either mental health or substance use disorder spending, depending on the primary diagnosis or the NDC on the claim. We'll move to the next slide. So these are the subcategories that I've mentioned. So this slide shows how we recommend the behavioral health service subcategories from the process map be rolled up into several higher level categories. So the categories would be used for reporting and for identifying spending that would be measured against a future benchmark. And again here, the other category would include claims with a primary behavioral health diagnosis, but without any other codes to identify to place them into a defined category. So next we'll move on to the non-claims spending module. So these are the principles on which our methodology for non-claims is based. This measurement includes a variety of methodologies for allocating some or all of a portion of a payment to behavioral health. And again, non-claims payments will be classified using HCI's expanded non-claims payments framework. And so that framework is used to classify total medical expense, alternative payment model, and primary care spending data. So the various methods here, I'll provide a brief overview, and then there are more details in your appendix. So the various methods include classifying payments for population health, behavioral health integration, and care management as behavioral health only when these payments are made to behavioral health providers. We also are limiting the portion that can be attributed to behavioral health spend from payments for practice transformation, information technology, and analytics. Those types of non-claims payments. And then we're including, of course, 100% of behavioral health capitation payments as counting as behavioral health spend. And then for capitation payments, we are allocating a portion of other types of capitation payments to behavioral health using a formula similar to the one adopted for primary care. So all non-claims payments identified as behavioral health will be included in the measurement of behavioral health spending. And then last, wanted to discuss our behavioral health and primary care module. If we could move to the next slide. So the measuring spending for behavioral health and primary care delivered in primary care setting, as distinct from the other behavioral health care, is intended to promote policy priorities such as the expansion of integrated care and greater attention to preventive behavioral health care performed in a primary care setting. So we are proposing to measure behavioral health in primary care through both our total healthcare expenditure data collection through DSG 3.0 and by using the Healthcare Payments Database, or HPD. And we are proposing this dual approach to optimize our ability to better understand this aspect of behavioral health spending and while minimizing data submitter burden. So if we could move to the next slide. So we have two proposed approaches here, a short-term and a long-term approach. So after several discussions with the investment and payment work group and review of public comments specifically about this module, we've landed on this phased approach. So specifically for our total healthcare expenditure data collection in 2026, which is the first year that payers will submit behavioral health spending data, we will capture a portion of behavioral health and primary care spending focused on care delivered by primary care providers. And this measurement will include claims-based payments within the outpatient professional primary care subcategory, and then non-claims payments for primary care and behavioral health integration. So that's a specific subcategory of our non-claims payments framework that we collect. And all payments will also be captured in our primary care spending measurement. So again, as a reminder, this module overlaps both the behavioral health and the primary care spend measurement. And in the longer term, over the coming year or so, OCA will conduct iterative analyses using HPD to explore how to refine the methodology to include integrated behavioral health provided by behavioral health clinicians who are not part of our current primary care definition. And those methodological refinements could include an expanded list of primary care providers and perhaps additional services that are designated to be only behavioral health services, such as psychotherapy. So we hope that these HPD analysis will give us greater insight into how to bring in, additional behavioral health spending in a primary care setting into this module, and while also making sure that behavioral health services is truly integrated. And the goal here is also to not count or not overcount non-integrated behavioral health services. And so with that overview of our definition, I will turn it over to Debbie to summarize the feedback that we've received from public comment as well as from the advisory committee on the definition and measurement methodology.
Thanks, Margareta, and good morning. So I will start with a summary of the public comments on the behavioral health definition and OCA's planned responses to them. OCA received a total of 7 public comment submissions during our comment period in August. One of those was a joint comment letter submitted by 5 organizations representing consumers or specific population groups. 3 were comments from organizations representing providers. We got a comment from 1 quality organization, 1 organization representing payers, and 1 from a labor organization representing healthcare workers. All of those comments are posted on the OCA website along with the materials for today's meeting. Moving to the next slide. First, we'll look at the comments we received on the measurement methodology. Regarding using diagnosis as the principal means of defining a behavioral health claim, one comment expressed support for this approach as opposed to using provider taxonomy. 3 comments addressed using only the primary diagnosis to determine whether a claim was for behavioral health, suggesting that this was too restrictive and that including claims with a secondary behavioral health diagnoses or other ways of capturing all behavioral health services should be considered. OCA believes that including spending from all claims with a secondary behavioral health diagnosis would significantly overcount behavioral health spending and would also impose an additional burden on data submitters. One comment urged OCA to include G codes related to dementia, which are codes for diseases of the neurologic system, in addition to F codes, which are used to classify mental, behavioral, and neurodevelopmental disorders. The commenter stated that G codes are more likely to be used in capitation arrangements. In response to this comment, OCA will evaluate the inclusion of G codes in the code set and also notes that G codes are not generally considered behavioral health diagnoses. When defining claims as behavioral health spending when there's no primary diagnosis, one commenter suggested using specific procedure and service codes in addition to the screening and assessment codes that are already part of the definition. OCA feels that expanding the list of services that do not require a primary behavioral health diagnosis would add data submitter burden and also increase the risk of overcounting. Though OCA is open to future consideration of allowing certain services that are always behavioral health related, such as psychotherapy, to be included without a diagnosis. Go to the next slide. A commenter encouraged OCA to incorporate encounter data into the methodology. And I'll note that encounter data is, in fact, used in the non-portions part of the methodology to allocate portions of capitation payments to behavioral health. 2 commenters suggested some place of service codes to include in the definition, such as partial hospitalization, long-term care, and intensive community treatment. And we want to emphasize here that behavioral health spending associated with these places of service is included in OCA's measurement. Our methodology uses place of service codes, revenue codes, and other codes only to categorize spending, not to determine whether it will be included in measurement. One commenter would like to see mobile clinic services as a subcategory to encourage provision of this type of care. The Investment and Payment Work Group discussed this issue and looked at data from the HPD, which showed minimal spending in this subcategory in the past. Also, the analyses of mobile clinic and crisis services that are of the greatest interest to work group members would not be possible with the data that OCA will be collecting to measure behavioral health spending. For example, work group members expressed interest in understanding utilization trends for mobile crisis compared to emergency department services. And OCA will look at HPD as a potential data source for these types of analyses and will continue to monitor the spending in this subcategory using the HPD. We're open to including a mobile services or crisis services subcategory in the future, incorporating what we learn from HPD analyses and from implementation of the measurement methodology. 2 commenters would like to see OCA include Medi-Cal data in the measurement of behavioral health spending as soon as possible, emphasizing that these payments, including those made by county behavioral health plans, are important components of the overall behavioral health spending picture. OCA agrees, and managed care plan spending on behavioral health will be collected in 2026. And OCA is actively working with DHCS to develop methods for analyzing spending by county behavioral health plans. One commenter urged OCA to include paraprofessionals in its definition. And as with the places of service, because OCA's definition of behavioral health claims is not restricted by provider type, any services that paraprofessionals provide will be included if they meet the primary diagnosis requirement. You can go to the next slide. So there were several comments on the specifications for the behavioral health and primary care module. In general, commenters supported the concept of the module for measurement and policy purposes. But opinions were divided about expanding the list of primary care provider taxonomies to include some behavioral health professionals, which was part of the methodology as proposed for public comment. One commenter supported the expansion so the measurement could capture a greater amount of integrated behavioral health and primary care spending, while two other commenters opposed the taxonomy expansion because of the risk of overcounting behavioral health spend that may or may not be integrated and the associated impact of overcounting primary care spending. OCA is sensitive to this potential for overcounting, and so in response to those comments and our discussion with the Investment and Payment Work Group, OCA has updated its proposal for this module to not expand the primary care taxonomies in the short term, and instead to use the HPD to analyze options for an expanded behavioral health and primary care module in the future. So this updated approach is the approach to the module that Margareta just reviewed. Another comment on the module suggested that to avoid double counting, OCA should count simpler services such as screenings and referrals as primary care only, and count more complex diagnoses and treatments as behavioral health. And we can respond here that these services, both the simple and the more complex ones, are counted in the module as both primary care and behavioral health. And the creation of the module allows the spending within it to be included or excluded from primary care spend and behavioral health spend. And the design makes it straightforward to avoid double counting of the included services. Go to the next slide. Regarding the board's decision to delay adoption of a behavioral health investment benchmark until at least summer 2026, none of the commenters disagreed with that decision. Two commenters explicitly supported the delay, and two urged OCA to use the time to fill data gaps to support a well-informed benchmark proposal. OCA is planning extensive analyses over the coming months to support benchmark development. One commenter expressed that the benchmark should encourage investment across the full continuum of care rather than focus on outpatient and community-based care. OCA notes that stakeholders strongly supported an outpatient-focused benchmark as we developed our benchmark proposal earlier this year, and OCA will revisit the question of the focus of the benchmark when our planned analyses are completed, and we will share those findings with stakeholders, including the Investment and Payment Work Group, the Advisory Committee, and the board, to inform future discussions of the benchmark. And one more slide on this. So finally, several comments went beyond the specifics of OCA's proposed methodology for defining and measuring behavioral health spending. Suggestions included that OCA should develop a plan and timeline for measuring out-of-plan, out-of-pocket spending, should address both spending and utilization associated with Z codes, which are codes documenting factors influencing a person's health status, including codes used to identify social determinants of health. Suggestion to document preventive and treatment services in various settings to assess access to care, to measure spending against unmet needs and desired outcomes, to measure cost savings associated with different care modalities, and to evaluate the payment rates for non-physician behavioral health professionals. So these are all important issues for understanding behavioral health spending and the state of behavioral health care in California in general, but they're outside the scope of OCA's data collection and can best be addressed as supplemental analyses or research studies. OCA will evaluate these suggestions and assess their feasibility using available data sources. Go to the next slide. Here we'll move on to input from the Advisory Committee in these next two slides from our meeting with them in September, including OCA's responses to their feedback. The Advisory Committee members expressed support for measuring behavioral health occurring in primary care and incentivizing integration efforts. And in response, as we've discussed today, OCA will continue to develop the behavioral health and primary care module, which aims to capture integrated behavioral health care and care provided by primary care providers. And we will leverage HPD analysis to refine the methodology for future data collection. There was a request to analyze claims and spending for secondary behavioral health diagnoses. OCA plans to conduct HPD analyses to identify spending associated with secondary diagnoses and will present our findings to the board. And there was also a request to consider how to capture behavioral health spending for Medi-Cal members under 21 years old for whom a diagnosis is not required to receive behavioral health services. So in response there, OCA's measurement methodology in the upcoming data submission guide will include spending on a defined set of behavioral health services for Medi-Cal members under 21 years of age, regardless of diagnosis. And OCA will revisit the suggestion to include some core behavioral health services, regardless of diagnosis, across markets as we plan for 2027 data submissions. Go to the next slide. So advisory committee members recommended that OCA consider ways to measure out-of-pocket, out-of-plan spend. And OCA continues to explore data sources and methodologies to analyze this spending by consumers. There was a suggestion to analyze the quality of behavioral health care. And OCA is researching behavioral health quality measures to monitor in addition to those already included in the OCA quality and equity measure set, such as depression screening and follow-up for adolescents and adults. Regarding the benchmark, advisory committee members expressed both appreciation for the delayed benchmark and continued support for a spending benchmark focused on in-network outpatient behavioral health care. OCA will conduct further benchmark-related analyses in the coming months and plans to revisit readiness to set a benchmark with the board in summer of 2026. There were comments on the impacts we're seeing and expect to continue to see of immigration policy and funding for school-based care on access. OCA acknowledges the impact of recent policy changes on healthcare access for California's most vulnerable populations, including immigrants and children. And finally, committee members expressed a desire to better understand the reasons for lower spend on substance use disorders compared to mental health and highlighted the frequent coexistence of mental health and substance use conditions. OCA is planning to conduct HPD analyses to identify the drivers of the spending trends for mental health and substance use disorders that we saw in prior analyses presented to the board this past June and July. And I'll finish by saying that Dr. Pan was the board member who attended the September advisory committee meeting, so unfortunately we won't have the opportunity today to hear from him any additional comments he might have about that discussion. We can go on to the next slide. So I'll wrap up with this timeline for the steps that remain for finalizing the behavioral health measurement definition. Following today's meeting, OCA will finalize the definition and measurement methodology within the coming month, including continuing to work with DHCS and Medi-Cal managed care plans to ensure that the final definition accurately reflects managed care plan spending. OCA will release the draft data submission guide for public comment in January 2026 and publish the final guide in the spring in preparation for the 2026 data submission in September. And OCA will include the results of its analysis of 2024 and 2025 behavioral health spending in its 2027 public report. And then throughout this entire time, OCA will continue to collaborate with DHCS and will engage county behavioral health plans in 2026 to prepare for future reporting of Medi-Cal specialty mental health and substance use disorder spending. And we can move on to the last slide. And we look forward now to hearing your feedback on the information we've presented, including the behavioral health definition and measurement methodology, and any additional thoughts you have about our responses to feedback from the public and the advisory committee.
Thank you very much, and very comprehensive in terms of looking at the feedback we have and the response back, and just appreciate the time to go through each of those components and have us able to hear those, that feedback and response. Comments or questions from the board? Sandra.
Thank you. A lot of really good work here. I wonder, I don't know, Debbie, I guess to you, what is the challenge with regard to getting the county specialty mental health data available to us sooner rather than later? I see us continuing to work on that with DHCS. It doesn't seem to me that, I mean, the counties report that data now, so what's the obstacle to getting that data sooner rather than later?
Sure, that's a great question. So I think it's the way they report doesn't kind of match our data collection for plans that we have within OCA, and so we need to develop a structure for analyzing data that they do submit to DHCS. And that is something we've been working on along with all the other things that we're working on. And so continuing to work with DHCS to develop that, but they don't fit neatly into our data submission approach that we have for other payers, nor do we want to add additional burden to them by asking them to submit directly to us. So.
Yeah, I mean, the specialty mental health component of our system is such a critically important system. So I would just urge you to continue to work closely with DHCS and County Behavioral Health to figure this piece out, because it really is just a big piece of the puzzle, and it would be unfortunate to start this work and not have that data. And then I know this question about out-of-pocket cost is something that we don't have a regular data source to be able to tap into. Has there been any progress in sort of thinking about other ways to begin to assess that part of spend?
Several months ago, or maybe even a year ago at this point, we did present an approach using the medical expenditure panel survey data. We're finding a lot of limitations with that data, and many kind of assumptions need to be made. So we do plan to return to the board in December to kind of conclude that that's probably not a viable pathway to estimate out-of-pocket, out-of-plan spending. And then we'll be seeing kind of what other approaches, such as survey data, which could potentially be commissioned by organizations to work on, might be a better data source.
Ian.
Thanks. On the question of double counting primary behavioral health, especially screening and assessment, I imagine part of the challenge here is if you're getting a payment on just one E&M code, it's very hard to figure out, how much to apportion to the screening or the assessment. I'm curious, have we received any input from providers about when we have that data, appreciating that we'll be able to assign it to one or the other or both? Do we have any input about how we might pass the payments and allocate a portion to behavioral versus primary?
So for the screening and assessments, one barrier that we've identified is that many providers don't use them as often as they actually perform the services, in part because sometimes there is no reimbursement for those. So incomplete, the coding data not reflecting the provision of care is a major barrier. But in terms of counting it as either behavioral health or primary care, if it occurs in a primary care setting, then it will be included in this module, which we can discreetly keep in or keep out to avoid double counting. So it will count as primary care. If it occurs in a primary care setting, it will also count as behavioral health, regardless of the setting in which it occurs. And then again, if we need to subtract, not double count it, we just subtract the module from a sum of behavioral health and primary care. So it's not difficult to parse it. It's just, yeah.
That's helpful. Thanks. Also, if I appreciate your mention of the longer term project here. I think our statutory charge is not just to reduce the amount we're spending on highly acute and specialty care and reallocate that spending to earlier interventions, but also to facilitate other system design. And I just encourage you, and especially in light of some of the public comment, that we look not just at payments, but really see if, with this potentially very rich data set, can we get metrics on, what portion of populations are moving from diagnosis into in-plan treatment, on what kind of timelines and so forth. I think that could be very useful to policymakers and health plans going forward.
Thank you, Rick.
Thank you, and I add my thanks for the very excellent work that you all have been doing. Following up on Sandra's question, it seems like even if we're not in the short term able to have the county behavioral health data in parallel categories to what we're doing with private health plans and with Medi-Cal managed care plans, that it would at least be useful to include some totals to say, here's how much money is being spent in county behavioral health, and to the extent that there are some breakdowns of that, even if they're not parallel to exactly what we've got, some indication of how that money is being spent, that would be very useful in the report. On the earlier question about out of pocket, out of plan, even if MEPS is not sufficient to really nail this going forward, I've seen some work that was reassuring to me in suggesting that the out of pocket, out of plan may be much smaller than numbers that have been talked about here and that have been occasionally mentioned in the literature. And to the extent that's true, it would also be useful to see that, even if we don't have a strong measure of out of pocket, out of plan, to at least give some indication of the magnitude. On Ian's question about screening, I had a similar kind of concern that I can imagine that in many wellness visits or annual checkups that there is a screening that gets done for either mental health or substance abuse, often very short, and we want to encourage that, and I can see the rationale for kind of counting that. On the other hand, counting the whole 160 or 130, whatever is paid for that visit as mental health, when the screening was probably a really small part of it, doesn't quite seem right. And it does sound like you're planning on receiving those data so that they can be reported separately. And if that's correct, then at least reporting separately will be important. I mean, I think if I can imagine, as you've mentioned, that a lot of the time screenings are done but not written down because there's no reason to write them down. They don't get paid extra for it. There still won't be extra payment for it, but now at least it will count towards the benchmark. And so medical group or health system that is actually concerned about reaching the benchmark may be encouraging their primary care providers, okay, if you've done the screening, write it down now. And it may be that a lot of the increase that we'll see in behavioral health spending will be a result of more screenings being reported and not really any real increase in behavioral health. And it'd be good to understand that. Might sort of following that down, that line of reasoning, it might make more sense to only count a portion of that wellness visit as being behavioral health, maybe to start out with, not go that far, but at least kind of consider that. And then the last question I had, you mentioned the interest from at least one advisory group members about counting, say, psychotherapy, even if the diagnosis isn't behavioral health. And I wonder whether from the HPD, is that I would think that that's pretty uncommon, that most psychotherapy visits have behavioral health, so it doesn't really matter. But if that thought is wrong, and for some reason there's a lot of psychotherapy being claims or encounters being recorded without a behavioral health diagnosis, then it would make sense to me to count that. And I wonder why we're not.
So there are a few things there. So for So appreciate the guidance on the county behavioral health spending. So we can incorporate that in our discussions with DHCS about even starting with total behavioral health spending at the county. For the screening for behavioral health services, whether they occur in a primary care setting or other setting, the guidance and the specifications that we have are at the claim line level. So we would not count the spending for the entire claim. But if there was, with a broader visit, there was a screening for behavioral health or substance use disorder, we would count that claim line that has the screening for behavioral health and substance use disorder. So the methodology is at the claim line rather than the entire claim.
But if there's a procedure code for the screening, I think it's fairly common that the payment is for the whole claim and not by each procedure code, or maybe that'll show zero payment for the procedure code, and then a payment for the wellness visit.
My understanding is that those procedure codes, those individual procedure codes that go along with a visit, whether it's an E&M visit or a wellness visit, can be paid separately, frequently are not, and perhaps if we're counting any spending that occurs on those claim lines, might incentivize payers to pay for them separately. But there are mechanisms for them to pay for each service that's documented, not only the overall arching visit. Again, that's my understanding.
And then for the question or the point about counting services such as psychotherapy even without a diagnosis, this has especially come up in the Medi-Cal space where Medi-Cal children especially do not have to have a diagnosis in order to receive behavioral health services or some behavioral health services. So that is our proposed approach, to start with making sure we're capturing that spending that occurs without a diagnosis for Medi-Cal members. And then more broadly, I think it's a good suggestion that we can aim to look at this in HPD beyond Medi-Cal to understand how many behavioral health services are occurring, or try to get a sense of behavioral health services occurring without a diagnosis and how often that occurs.
If I can have, thank you so much. One last question actually for Vishal, and I've just lost track of where we are on being able to attribute spending to medical groups.
So the payers have been sending us a attributed TME file, which is for attributing spending to physician organizations. We didn't report it in the baseline report the first year, but we are exploring reporting it in the second report, which is due, which we should have prepared around June of 2026, and it'll cover 23 and 24 data. Before we kind of decide to go forward, we just want to do some payer provider previews. So being able to meet with the large physician organizations to go over some of the data we have on them before we put out a report.
Thank you. This is probably in the out-of-pocket bucket, but in the commercial market, given the just profound lack of capacity, there's a lot of increasing reliance on various vendors like Talkspace or whatever. Will that be captured at all? It's a really growing sector.
So we will, if it is covered or under the mechanism of the health plan, yes, we will capture behavioral health services provided by a vendor, whether they are through a non-claims payment or through a claims process. So we are capturing, vendor services and telehealth services. For folks that go directly to those types of vendors and are cash pay, we won't be capturing that.
Is there a timeline for the cash pay piece? Because so many people are turning to that because they can't get anyone in network.
Yeah, because of the setback with the MEPS data, there would essentially need to be a new data source. So we think it's likely that if we want this data, somebody would need to do some type of survey, which includes speaking with consumers that receive surveys or counselors that provide the services directly and see kind of what the going rate is for these visits.
Okay, thanks.
Not seeing any other comments from the board, we are going to open up public comment on this item.
We'll now take public comment on this item. Please limit comment on other items to the general public comment period. Please limit your comments to 2 minutes or less. Looking virtually, seeing no hands raised, we'll go to the podium.
Hi again, Kei Yamamoto with the California Pan-Ethnic Health Network. We'd just like to add to the discussion that access to behavioral health services is hindered by affordability and cultural and linguistic competency, that consumers often are paying out of pocket for behavioral health care due to narrow provider networks, challenging prior authorizations, and other processes and shortages of providers and outpatient services. So California has yet to achieve that full parity of behavioral health with physical health, and this is a critical challenge for OCA. And we support the delay of the benchmark, but believe the delay should be time limited. We strongly concur with the board's request that OCA continue to analyze data from existing sources and revisit readiness to set benchmarks in 2026. Consumers cannot wait or continue to shoulder the burden of high behavioral health care costs. And the preliminary aggregated data of OCA shared with us in May showed significant cost increases in behavioral health across the continuum of care, while raising significant questions about underlying cost triggers. Understanding these triggers are going to help OCA to set the benchmark that's targeted and evidence-based. And then the short time I've left, I'd also just like to uplift that OCA should adopt a concrete plan and timeline for an alternative approach for supplemental analysis of out-of-plan, out-of-pocket spend. That integration with primary care is critical. And lastly, OCA should incentivize investment in outpatient behavioral health care. Thanks so much.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Beth Capel with Health Access. We signed on to the letter with CPEN, and so echo the comments of our CPEN colleagues. I would lift up that, like them, we think it's important that the benchmark emphasize outpatient and community-based care, while we're counting all care that's provided, and certainly every consumer should have the care they need, whether that's a hospital emergency room or residential setting. And we are fortunate that Governor Newsom has signed Senator Wiener's legislation to make sure that those are covered benefits. So we're in a better place than we would have been 8 years ago in terms of making sure consumers have access. But just as we don't provide care for asthma or diabetes or heart disease in an emergency room, if we can avoid it, we shouldn't be providing behavioral health care in that setting either. The final point I would add is that there is a paucity of equity and quality measures on behavioral health. We recognized this when we were dealing with the Department of Managed Healthcare's effort to establish metrics. Your law requires that you use recognized measures, but the national quality folks don't seem to regard behavioral health as worthy of attention, and that's a problem that should get rectified. So, and the final point on that is, as CPEN said, the equity implications of the lack of affordability of behavioral health are devastating for too many of our communities. Thank you.
Thank you. Looking virtually, seeing one hand raised. Ciara, please go ahead. One moment. We'll unmute you on our end. All right, go ahead. You
Hello.
might need to unmute. Yep.
Hello, Kira with the National Union of Healthcare Workers. We appreciate the board's work and would like to echo what CPEN said around the delay of the spending target. We agree with the delay, but agree also that it should be time limited. And we'd also like to uplift that it is critical to better understand the out-of-pocket costs of behavioral health care. And we encourage the board to quickly move to adopt a method and timeline for surveying this spending, as it will be important to better understand the needs of patients and providers. Thank you.
Thank you. Looking back to the podium, seeing no one at the podium, seeing no other hands raised. That concludes public comment on this item.
Thank you very much, and thank you again for the continued work on the behavioral health component. We're going to now move to item 5, which is closed session as noted on the agenda to discuss matters related to the California Hospital Association versus the Office of Health Care Affordability and all. We expect that session plus a lunch break to take us to 12:30, which is our estimated time of reconvening. We'll start with public comment. Okay, I heard 12:45 coming. We will reconvene at 12:45 and start with public comment there. And then we have a remaining item 6A, Monterey Hospital Market Competition, as well as general public comments to conclude our meeting today. Thank you very much. With that, we'll move to closed session.
Okay, good afternoon. That's Secretary Johnson had to leave us, so I'm going to pinch hit for the rest of the afternoon. Let's do roll call, please.
Good afternoon, Dr. Sandra Hernandez.
Present.
Secretary Kim Johnson. Richard Kronik.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Dr. Richard Pan. Don Moltz.
Here.
5 in attendance, 1 absent. 2 absent. Sorry.
Okay. We will take public comment on our closed session, if there is any.
We will now take public comment on the closed session item. If you have a comment, please step to the podium. If you are dialing in, please press *5 or raise your hand if you're attending virtually. And this was the closed session to discuss related to litigation. All right, seeing no one at the podium and no hands raised, that concludes public comment on this item.
Great, we'll move to item 6A, and Sheila, I'll give it over to you. Thank you.
Good afternoon. Introducing myself again for the people in the room and virtually, Sheila Tatayan. I'm the Assistant Deputy Director for the Compliance Branch of OCA and also the Assistant Chief Counsel. So we are to the agenda item of the Monterey Hospital Market Competition Study. And I really don't have to tell you, you were there in numerous meetings where you heard public testimony about the high cost of care in Monterey County. You heard from so many consumers about their individual stories of how they and their families have been impacted. You heard from the labor unions and you heard from the hospitals. So you probably remember that in August in Monterey, the question from you all was, well, what can be done? So we looked to what we have in our toolbox, and by statute, if we could advance to the next slide, OCA has statutory authority to do studies and research and to really look at situational severities. This is what I'll have to say, situational severities, which Monterey County is. And so we brought to you the idea of doing an investigative study of hospital market competition in Monterey County. And so in October, our director ordered that we do this study. So here we are, just a little over a year later, with a lot of work and some excellent experts that we retained for the study. And they are here today to present the study to you. And I want to introduce them. Dan Arnold from Arnold Analytics and Paul Ginsberg. He's online virtually. You can see him on the camera there at the front of the room. And Katie Gudikson. And Dan will be the first.
All right. All right, it's a pleasure to be here with you all today to discuss this report. And just before I get started with the outline and get going here, it's really been quite the team effort, I think, all around. And last year, you saw the people in Monterey come to OCA and present their concerns. Through this report, we spoke to a lot of different, I guess, stakeholders, as you will. I'm not a huge fan of that term, but stakeholders in Monterey, and Katie will be talking to you about what they shared with us. But every time we reached out, they wanted to talk to us, and so it was very kind of, the people in Monterey are very enthusiastic to talk about this, say their concerns again, and are happy to hear or have someone out there listening and looking into the concerns that they're bringing to the table. So between the people in Monterey and the people at OCA who have been with us kind of all the way with this report, it's nice to finally be here and presenting it to you all. So just as an outline on the report, the whole report is posted, but for this presentation, this is what we're going to go through. We're going to start with a background on Monterey County, kind of catch you up, remind you where we were a year ago when this report was asked for. Then we'll go from the background to an analysis of the hospital prices using, these are new price analyses that we did specifically for this report. Paul Ginsberg then will jump in and talk about what high hospital prices mean and look through the factors of why we could potentially see high hospital prices. You could have high costs, you could have high wages, your quality could be higher. Those are kind of the things that we think about that could be driving high hospital prices. So Paul will go through some of that and show you what we find in those dimensions and how much those things can explain high hospital prices. Paul will also talk about cost shifting. And then towards the end of the presentation, Katie here will go through what we think the reasons are for the high prices, policy options to address them, and then conclude. Okay, so to start with the key findings, 4 key findings to preview this presentation. New hospital price analyses using data from CalPERS and Covered California show that Monterey County has the highest inpatient prices in California and the 4th highest outpatient prices among California counties. And so this is true after adjusting for a whole bunch of factors, including higher wages in Northern California, which we all know to be true. Just generally, everything is more expensive in California and Northern California versus Southern California. So after all those adjustments, we still see that Monterey County ranks the highest in terms of inpatient prices and the 4th highest in terms of outpatient prices. And coincidentally, that was true, exactly true for the CalPERS data and the Covered California data. They both ranked 1 for inpatient, 4th for outpatient. So the concordance there, I mean, it might not be surprised that those line up so well, but it is interesting that they do. The 2 sources we use for the price analyses almost line up exactly in terms of where Monterey County ranks. Sorry. And then we'll go through the other key finding here is that that computer. Okay. All right. There we go. So then we go through the possible reasons for these high prices. So the obvious ones are you have higher operating costs. So higher costs mean higher prices. The other one you could think of would be wages. If the wages of the people that are staffing the hospitals have to be much higher,
then that's also a cost to you, and then your prices as a result have to be much higher. And the other thing that could explain high prices is quality. If you're producing much higher quality, then there is some justification for higher quality leading to a higher price. We don't find that to be true. There's no signs of higher operating costs in Monterey County, no signs of higher wages, no signs of higher quality. So, and we'll get there, but what we mean is this mainly comparing to other counties in the Bay Area. So it's true that Monterey County's costs, wages are higher than Southern California. It's not true that they're outliers in terms of Northern California. And the quality appears to us as good, but not extraordinary, I would say. Then the high price percentages of Medicare and Medi-Cal patients also gets raised as a possible explanation for having to have higher prices on the commercial side. This is the cost shifting hypothesis. There's a lot of literature on this, which Paul's going to walk through, and exactly what that literature says and what we make of that literature. And then what we ultimately find is it seems like there's just a lack of competition in Monterey County. After ruling out higher operating costs, wages, and higher quality, it leads us to the conclusion that there's a lack of competition, and that's the reason for the higher prices. Okay, so to start with the background, Monterey County, population of just over 400,000, mostly rural. The largest cities are Salinas, Seaside, and Monterey. Salinas by far the largest at 160,000. Seaside and Monterey both 30,000. Population mostly in the northern coastal areas in Salinas Valley. We'll show you a map soon. The remainder of the county, particularly the southern part, very sparsely populated. And we have a lengthy drive between the two population centers in Salinas and Monterey, which partially explains why you see some of the things, some of the dominance in the local regions between the hospitals that are on the east side of the county and Community Hospital of Monterey County of Monterey Peninsula on the western side of the county. So the economy is based on tourism, retirement living, and agriculture. And the three hospitals we're talking about here are the Community Hospital of Monterey Peninsula, Natividad Medical Center, Salinas Valley Health Medical Center. There's a fourth, much smaller general acute care hospital it's Me Memorial Hospital in the southern part of the county. We did look at that as whether that was providing any sorts of competition to the other three. It turns out it's really not. There's not people from the southern part of the county going up to the other three hospitals, and the other three hospitals really don't lose any kind of patients to Me Memorial when you look at kind of patient flow things. So for the rest of this report, we're going to be focusing on these three hospitals. Okay, so starting with Community Hospital of the Monterey Peninsula, or CHOMP, 250 beds, nonprofit, part of Montage Health, which also has Montage Medical Group, the MOGO Urgent Centers, and Aspire Health, which is a Medicare Advantage plan. The payer mix, and this will be important for cost shifting when we talk about cost shifting later. The public payer mix is 63% for CHOMP. The statewide average 62%. So no kind of payer mix outlier in terms of payer mix compared to the statewide average. Next is Natividad Medical Center, more on the east side of the county. It's 172 beds. It's a county hospital, which means it can directly employ physicians. It's the safety net hospital in the county. And the payer mix here, the public payer mix is 78% in 2022. So for Natividad, a bit higher on the public payer mix than the statewide average, 62%. And the third one is Salinas Valley Health Medical Center, 243 beds. It's a district hospital, part of the Salinas Valley Health system, which also has the Salinas Valley Health clinics, including both primary care and specialty care, and the payer mix 70% public for Salinas Valley. Okay, so previous studies have shown the high prices of these 3 hospitals in Monterey. This is material that Chris Whaley presented last year from the RAND report. The blue columns here that's the California average as a percent of Medicare. So we start with the collection of 5 bars on the left, commercial hospital price, and the California average is 287% of Medicare. The Bay Area average is above that at 320%, and then the 3 Monterey hospitals fall even higher than the Bay Area average at 340% for Salinas Valley, 420% for Natividad, and 466% for Chump. If you look at inpatient facility prices, that's you see some particularly high outliers, which is kind of what we see in the data, that inpatient side is higher than the outpatient side. Inpatient facility prices, the Bay Area average is 311%. You have Salinas Valley at 378%, Natividad at 465%, and Chomp at 572%. You go to outpatient, it's Monterey is above the Bay Area average, but only slightly in this case. And you look at professional services, the final group of 5 columns there. These are what the physicians get paid. This is Monterey County does not look like an outlier in terms of physician payments, which they're actually, the California average is 185% of Medicare. The Bay Area average is 215%, and all 3 Monterey hospitals actually fall below the Bay Area average of 215%. So that previous price, those previous price results, plus this is another national study done by the Healthcare Cost Institute that looks at the Salinas metro area, which Monterey County is a part of. And if you're wondering if it's a story whether the prices are high or the utilization is high that leads to higher spending in the county, it's clearly the prices here. It's actually utilization ends up being lower in the Salinas metro area than the national median in terms of utilization, but the prices along all dimensions, overall inpatient, outpatient, and even slightly higher on professional, the prices are all above the national median for the Salinas metro area. So for this study, we did a couple new price analyses using data that CalPERS and Covered California graciously provided to us. So for CalPERS, we used data from facilities claims data for all their members, and these data go from 2013 to 2023. And for Covered California, the data starts a little later, but similar data, facilities claims data for both individual and group products from 2018 to 2024. And so the first thing we do is wage adjust all prices, which I'll explain in a minute. And then we looked at common procedures or common types of admissions on the inpatient side. And then we looked at common procedures on the outpatient side. So some of the procedure names will be familiar to you when we get to them, but we just took kind of the most common types of admissions you can think, looking at across a number of these admissions and a number of these procedures, and just looked where Monterey County fell in terms of wage adjusted prices. So nothing overly complicated there. And then if you want to make sure you adjust for everything that might matter in terms of higher prices, you should adjust for things like the age, sex, and complexity of the types of services being done at these hospitals, and then compare the prices. So we'll show you some more adjusted price analyses that adjust for a number of things, and then after all those adjustments, then we compare counties again using that. So those are the two kind of price analyses that we've added here. So first, what we mean by wage adjusted. So if you have say a hip or knee replacement and it costs $20,000-$30,000, and you're doing that $20,000 hip or knee replacement in Northern California, and someone's doing that in Southern California, Los Angeles, at $20,000, you should kind of in a way get credit for doing it at $20,000. You should get more credit for doing that in the Bay Area than you should in LA County. So this map here shows you what the wages are across the state using the Alternative Medicare Wage Index by county. This index is 1 nationally. So in California, the index, the county with the lowest index has a 1.12. So the wages in all counties in California are above the national average. And then it goes up to 1.62 as the highest wage index in California, and that's in San Francisco. So you see Monterey there, it is in the red, it's not in the dark red. So in terms of the wage differences, they are high wage, but not the highest wage compared to other counties in the Bay Area. So the first new price analysis, this is looking at the 10 most common inpatient admissions in the CalPERS data. And we found that if you look across those 10, and the full names are of these admissions are in the report, but the first one there is major hip and knee replacement, septicemia, you see C-sections third. You go along, a lot of these end up being deliveries, which is no surprise. But if you look across the 10 most common types of admissions, for all but one of them, the Monterey wage adjusted price of that admission is above the Bay Area average. So that's going from 18% above for septicemia all the way up to 168% above compared to the other hospitals in the Bay Area. And if you do, now you look at the common outpatient procedures. This is again using CalPERS data. You have things like x-rays, colonoscopies, ultrasounds, all sorts of common procedures, CT scans, and you go along starting with the lowest or the percent above the Bay Area average, the lowest percent above, or it's actually below at the beginning, going all the way to the right. You see one of the procedures is 200% above the Bay Area average. Averaging across all 23 procedures, you see that outpatient procedures are 47% higher in Monterey than the Bay Area. Adding in those additional adjustments I mentioned in terms of age, sex, and severity of the cases that these hospitals are seeing. You factor all those things in and you get one average, or you get one adjusted inpatient price, adjusting for all those factors for each county. You see in terms of inpatient adjusted prices, Monterey County is the highest. And a similar adjustment procedure for the outpatient price gives you one price by county at the end, and you see that Monterey has the 4th highest adjusted outpatient price using CalPERS data. And so that's those are the new price analyses and supportive of previous price analyses. Doing things a similar but different way leads to kind of similar conclusions to what we knew before. Now I'll switch it over to Paul now, who will present virtually on what we think, or he'll first start talking about premiums and then go through potential reasons why the prices might be high.
Sorry, I just wanted to note, so you have, I think, slide 46
which shows Monterey relative to benchmark Bay Area. The hip and knee piece, so we have a reference pricing program in place for hips and knees. We have it in place for a lot of other procedures, but the mechanism is different. For this, it's just a straight reference price, which is the explanation here for the low cost, particularly compared to everything else. That it's just a single price across the state. So that's what's going on there, and why that one little slice of this very otherwise ugly chart is looking pretty good.
Yes. Yes, important context. Yes. Thank you for that. All right, I'll go back. All right, slide 50. Okay. All right, Paul, it's all yours.
Paul, you need to unmute your mic.
Oh, good. I just did, and clear. I'm really pleased to be here, and we'll continue on from where Dan left off. So, Dan showed how prices are higher, and this slide shows how premiums in Monterey are higher, and that's where the problem is. And not only are they higher, but they're rising faster than the state average. So in 2024, the gross premium for an individual, this under covered California, was $884. I guess that's per month. And this was significantly higher than the statewide average of $655. What's also kind of shocking is the trends. The average increase in Region 9, which includes Monterey County, was 10.9% a year, while the statewide average was 7.6%. Could you move to the next slide? Yes, so the impact of high hospital prices is higher premiums. And if you look at the bulk of the private insurance, this is employer-sponsored insurance. Oh, wait a second. I think you skipped the slide. Can you go back one? Yes, that's it. So in employer-sponsored health insurance, high premiums means increased difficulty in affording coverage. And it also means for those employers that still can afford the coverage, higher premiums, higher contributions by employers and employees. And a fair amount of economic research has shown that higher employer contributions are shifted to employees. So we're talking about, this burden of paying higher premiums that ultimately is winding up with the employees. It tends to show up as smaller wage increases over time. It also shows up as higher cost sharing. Deductibles increase, coinsurance rates increase. And, with health insurance being a fixed per person amount, it means that these increasing premiums are particularly burdensome to low wage employees. And this notion was corroborated quite extensively in interviews with union leaders, which Katie will talk about these interviews in more detail. And unions have actually been encouraging members to get some care outside of the county, where the prices are lower whenever it works for the members. Can you next slide, please? Yeah, so the increase also, high premiums lead to an increased incentive for employers to outsource low-wage work. So low-wage employers provide more limited coverage, so incentives to outsource the housekeeping, security, services you're familiar with being outsourced from many large employers, because the low-wage employers will have more limited coverage or perhaps no coverage at all. These, the trends of high premiums are burden extensively governments at the federal, state, and local level. So the exclusion of employer and employee contributions from taxable income, which happens at both the federal level and with California, lead to very substantial losses of revenue. The U.S. Treasury Department projects that for fiscal year 2026, that we're in now, that there'd be a loss of revenue of $309.4 billion. We don't have numbers for California, but the losses of revenue is likely large as well. Governments experience higher costs for public employee health benefits and also higher spending to subsidize coverage for low-income people. So, when covered California premiums increase, there's an automatic increase in the federal ACA subsidies per person. And some employees who lose coverage from their employers will qualify and enroll in Medi-Cal. Next slide, please. Now, why are hospital prices so high? Dan has covered this, but I'll just go over them quickly. And these are the factors we looked at: high operating costs, high wages, high quality, cost shifting, or the lack of hospital competition. Please advance. Now, higher operating costs do not explain the higher prices. This is a different way of looking at it. Each bar in this graph is for a particular hospital in the Bay Area. And you can see that the three red lines, which are the hospitals in Monterey County, going from the left, the Salinas Valley, then Natividad, and then Chomp, they're kind of roughly in the middle. Their operating costs do not stand out. Only their prices. Next slide, please. And it shows how higher wages do not explain the higher prices. This is Bureau of Labor Statistics data for metropolitan areas throughout California for registered nurses. And you can see that the Salinas Valley metropolitan area or Salinas metropolitan area is generally in the middle. Many metropolitan areas in California, particularly in the north, have higher wages for registered nurses. Next slide, please. Higher quality does not explain higher prices. Quality is not a problem in Monterey County, but the hospitals' quality ratings are kind of average, except for Salinas Valley's rating of overall star rating of 4. All of these, the star ratings and the patient survey ratings, are average, as is the state of California, and of course the national average. Could you advance the slide, please? Okay, the next couple of slides, identifies the particular aspect of quality where one of these hospitals is either worse or better. And we can see that for serious complications, CHOMP is worse. For C. diff, all three are better. And advance the slide, please. And for death rates for patients, death rate for heart attack patients, CHOMP is better. And death rate for pneumonia patients, Salinas Valley is better. Next, please. Okay, now I want to talk about cost sharing, shifting. The term is used to describe how a hospital reacts to either payment rates from public programs like Medicare and Medi-Cal not keeping up with the cost of delivering care, or actual reductions in payment rates in one of these programs. And the theory, and this comes from mostly from hospital and insurer executives, is that hospitals respond to lower or more slowly rising payment rates from public payers by raising prices that are going to be paid by private insurers. And I want to point out that this is distinct from the common practice of what economists call price discrimination, which is simply the act of charging different payers different prices for the same service. So, almost all hospitals have higher prices for private insurers than where they have some negotiating ability than from Medicare or Medi-Cal, which are set by those by governments. Now, this theory of cost shifting is not at all supported by economic research, and there's been a lot of it over the past 15 years or so. Economists, their theory is that most hospitals always negotiate as high a price as possible with private insurers. And when I say as high a price, I'm really talking about the price that maximizes their revenue from private insurers, at least on a per person basis. And the empirical research shows that most hospitals respond to either a cut in public payer rates or lack of increases, either by increasing their efforts to reduce costs, by selectively reducing prices to private insurers to increase services for privately insured patients, since those payments are higher, or accepting lower operating margins. Next slide, please. So this is a graph that was presented to you last year by my colleague Chris Whaley, and it shows how cost shifting doesn't explain variation in California hospital prices. It shows that those California hospitals with more publicly insured patients have lower prices, and a 10% increase in non-private patients in non-private patients is associated with a 4.4% lower prices, or 10% higher government payers leads to 5.4% lower prices to private insurers. Next slide, please. Now, I want to bring up the concept, because I think it's very relevant for Monterey County, of hospitals with must-have status. What I mean by must-have status is that some hospitals are in a situation where insurers really need to contract with them if they're to offer a commercially viable network. In a sense, if they don't include must-have hospitals, they're going to get very little take-up by employers or individuals buying their coverage. So some characteristics of hospitals that lead to this is, a stellar reputation, a very large market share in the area, being the sole hospital in a rural area, but in metropolitan areas, only a small minority of hospitals have this status. Prices at must-have hospitals may be lower than what the market would support. So what I'm saying is that if a hospital has this clout with insurers, it may be in a situation where it could actually charge higher prices if it wanted to, but it may refrain from that because of the impact on the community. Its board members may be saying, no, don't raise prices more than you really need to maintain your quality and in your ability to grow. And that so if a hospital is not using all of its clout, then if public payers are paying less or don't increase their rates fast enough, they may increase their prices. And that would be cost shifting. Now, the interviews that Katie and I conducted showed that the three hospitals in Monterey County all have this must-have status. And this might explain some, not all, of the higher prices for particularly Natividad and the Salinas Valley Health Center. Next slide, please. Oh, I think this is time to switch to Katie.
Thanks, Paul.
Yes, can you say a little bit more about Salinas Valley and Natividad and the must-have observation? They're right next to each other, and I mean they're within a few miles of each other in Salinas, and just wondering what led you to that conclusion.
Sure. Well, certainly, because there's another hospital, there are two possibilities. Natividad is the only hospital with a trauma center. So if an insurer knows that they're going to have they might have trauma patients, they're all going to go to Natividad, well, might as well have a contract with Natividad rather than pay much higher prices whenever one of our members arrives there for trauma care. You could say that, clearly with Salinas Valley not having this unique thing, that they have less of a must-have status than Natividad does. And, when you look at the data, that kind of lines up with that Salinas, their prices are lower than Natividad's and much lower than Chomp's. So, that's my sense of what we might be seeing.
One other just quick follow-up. So if you have some necessary services in one of the two hospitals that are approximate to one another, is it that it's must-have for that particular set of services, or are you suggesting that those services give the hospital leverage for the rest of their contract, or how does this?
Yeah, it's really the latter, that insurers are not contracting. I don't think a hospital that is a trauma center would say to insurers, "Oh, we'll contract with you for trauma care, but not for the other services." Yeah, I think that's how it would work.
If I can follow up on that. Hi, Paul. It's Rick. Nice to see you. You mentioned on that same slide that Chomp also has must-have status, but in the last bullet, you don't say that the must-have status at Chomp might explain some of the higher prices for Chomp. Maybe I should wait till later. You're going to come back to this. It may be related to the kind of lack of competition, but I'm kind of missing a little bit something there.
Oh, sure. Yeah, it's probably our lack of clarity. Basically, Chomp has, probably has the strongest of the must-have status. But what we say, and it's in Katie's slides, is that the public payer percentage at Chomp is really virtually identical to the statewide. So in a sense, we're saying that they have must-have status, but it doesn't explain why their prices are higher than the rest of the states.
I will look forward to Katie's presentation here. Yeah, thanks.
There we go. So up to this point, we've kind of looked at data analysis, kind of the what, and I'm going to talk a little bit about the voluntary confidential interviews that we conducted in the area, trying to put some context in these numbers and sort of begin to talk about the why. And so there, we talked to a number of people in each of these categories: physician and physician organizations, health systems, insurers, and labor unions offering coverage in Monterey County. And if you forgive me, I'm going to jump ahead to the payer and come back to the system. The slides were. So first I'm going to talk about payers. And by the word payers, I'm actually grouping the labor unions and the insurers together when I talk about these results, because they're the ones paying for the care, and basically the results we heard from them were very similar. And the overall message, I think, from these interviews was that the payers believe that a lack of competition is the primary reason for the high prices. We heard over and over that Monterey County functions like a rural area, even though it may not look like many other rural areas in California. Here are two quotes that we heard. Network adequacy is the biggest regulatory hurdle to having leverage with hospitals. And then also in that area, dropping any of the 3 hospitals would be very hard. In that area, 20 miles may well as be half a world away. It's a commercial viability problem. And as Paul said, payers and especially the labor unions talked about how they encouraged members to obtain care from outside the county, talked about how they often paid travel expenses both for the patient and a companion, and that was often cheaper than actually getting the care in Monterey County. I'll also note that there was minimal managed care in the county, which was also unique in California. Even Medicare Advantage enrollment is very low. It's only 15% in Monterey, and it's 52% across the state of California. And that's what we heard, was that because the must-have status of the hospitals allowed them to not only dictate the prices, but they could also basically dictate the terms of the contracts. And that's what we heard from the payers. Now to go back 2 slides to talk about the health systems that we talked to. There are more details in the report. What I'm going to present today are the things that we found a little bit surprising or that helped explain some of the results. And so what we found perhaps most surprising was the health systems described low or negative margins for professional services, basically for the medical groups that are affiliated with the system. And we were told that it was due to historical contracting practices. We tried to do an analysis of physician data, sort of tying them to medical groups and sort of compare them. The data wasn't very reliable. And so we looked instead at financial statements and tax filings that we could find. We did find low margins for the Salinas Valley Health Medical Group, and Montage Medical Group's tax filings showed that it had operated at a loss for 13 consecutive years, with the exception of 2020, where they did have a profit, but we all know that was an exceptional year. So what do these imply? There we go. So I think it is fair to say that operating losses on physicians could explain a portion of the very high hospital prices, but not the bulk of it. We had trouble actually quantifying this, but it appears to be a relatively small percentage of the very high, exceptionally high hospital prices. In addition, low physician prices could actually be a barrier to entry for new physicians in the area if physicians are being paid less in Monterey County, and they're, especially physicians moving into the area, they may choose to go somewhere else if they can get higher prices elsewhere. And I would also just note that if we talk about constraining hospital revenues, if before they're shifting profits or subsidizing sort of physicians with the high hospital costs, if you put pressure on the hospital costs, some kind of price limitation, we could expect that they could substantially increase physician prices rather, if they're no longer able to subsidize physician salaries through high hospital costs. Do you want me to keep going? I see a, okay.
If you don't mind. I gather in the hospital market, you have to have CHOMP, and that lets CHOMP negotiate for very high prices. Is it the case that an insurer could offer a viable product without Montage Physician Group?
We did not hear that was something that the payers basically considered.
And I guess so I'm a little bit not quite understanding if you have to have Montage medical group, which I imagine you do, why are the prices that Montage Medical Group is getting kind of lower than average or low?
No,
Yeah.
Montage is owned, I believe, 51% by Chomp and 49% by Salinas Valley. So I think that's germane also.
And we could, I can move ahead to the physician practices and basically show that a number of the physicians in the area are basically aligned with the big health systems. So it isn't really possible to construct a network without physicians that are very closely aligned with the hospitals. Is that?
I mean, that makes sense, but then why aren't they able to get better prices?
What we heard was it was a historical, it used to be there were very few physicians in the medical groups affiliated with the hospital, so they didn't mind taking a loss. It wasn't worth their time to negotiate. And over time, it's become a bigger factor. And so you might expect that might go up in the future, especially if there are constraints on the hospital prices such that it makes sense to sort of balance that out.
Yeah, and Katie, if I can add something, my hearing and the meeting interviews you were at was that, oh yeah, they're really low, and we could have raised more, but basically, I think it comes down to they just set that the inpatient and outpatient facility prices at what they need revenue-wise, and they don't kind of have a battle with insurers over physician professional fees when they have all this ability to raise the facility prices.
So I'll move on, and I'm happy to take more questions at the end. But we also talked to physicians both in all kinds of practices and organizations that represented physicians as well. And we note that there's been a consolidation of physicians with hospitals in Monterey County over time, especially in the last 5 to 10 years. These sort of reflect changing physician practices nationwide as more and more physicians are wanting a salary and wanting to be affiliated with hospitals so that they don't have to open their own practices. And I do want to note that we didn't find evidence that sort of hospitals were actively going out and trying to recruit physicians, but just that this sort of alignment over time, more and more physicians were a part of these groups. There are a few independent physician practices in the area, but all the largest medical groups are owned by a health system. Most physicians in private practice had admitting privileges at only one of the hospitals, and that seemed to be physician choice. We didn't find any evidence that the hospitals were demanding that, but simply physicians didn't want to drive the 20 minutes between the facilities, and they didn't want to take call at more than one hospital. There we go. And so what does, sorry. So what does this mean? I just wanted, there's a whole discussion of the peer-reviewed research in the report that you can read if you want to. But the evidence from lots and lots of peer-reviewed studies is that this kind of physician affiliation or alignment increases prices, both at primary care physicians affiliated with hospitals and specialists. It can increase facility fees, and that the hospitals can start to charge facility fees for services that used to be delivered in a physician's office without those facility fees, and also that you typically see after this sort of affiliation an increase in referrals to higher price facilities like hospital outpatient departments instead of lower cost places of getting care like a physician's office. In addition, vertical consolidation creates basically a barrier to entry at all levels, because if a hospital wanted to open in Monterey County, they'd be forced to find physicians. And if a physician wanted to open an independent practice there, they would need to basically affiliate with a hospital. So it's not surprising. You've heard quite a long discussion that the preponderance of the evidence is that a lack of competition is the reason for the high hospital prices. And the highly consolidated and insulated market structure in Monterey County means that regulatory actions such as antitrust enforcement or traditional market-based policy solutions like encouraging new hospital construction are probably unlikely, especially in the short term, to do much about high prices. So I will talk very briefly about a few policy options to constrain hospitals, one of which this board is intimately familiar with. These are spending targets. These are already in place, basically, and the board has already identified Chomp and Salinas Valley as high-priced hospitals. So I just want to sort of remind everyone that this approach requires entities to strategically manage growth in prices or volume or both. It doesn't actually require cutting prices. It incorporates existing prices disparities because the spending targets are based on existing payment rates. They're a percentage of that. And they're also, by their nature, retroactive because you measure the performance year and then there'll be some enforcement after the fact. And so I just wanted to describe briefly two other options that are out there. Note that these aren't recommendations. I just wanted to present that there are some options out there. One is to simply cap prices at Medicare-based price caps. So you can limit commercial payments to a set percentage of Medicare rates. In theory, you could choose anything you want, but Medicare is a publicly available, well thought out set of structures, set of payment rates. It does focus on hospitals with the highest prices because the rate could be set, at those high races, at the rate of the high hospital prices. I will note that implementation can be complex in a situation like this because not all payers in the county necessarily follow the same payment models that Medicare uses, like DRGs. So it can be hard if there's capitation, case rates, bundle payments, et cetera, in the area. It just makes implementation more complex than you might initially think. And again, Medicare rates are not always representative of costs to provide care to the commercial population, sort of especially in maternity or pediatric care. So you might have to find another way to set those rates. Certainly there are ways that have been done in other states, et cetera, to address that. And the other policy option I just want to bring up are hospital global budgets. And in a sense, they're sort of a hybrid between price caps and spending targets because like spending targets, they allow the hospitals to strategically restrain costs and types of care or volume of care. In the same way you're letting the hospitals make the strategic decisions, you're just setting a budget for the hospital. And hospital budgets can be fixed, so it's sort of a guaranteed income throughout the year. They can also be variable, such that you sort of cover the fixed costs of operating the hospital, and then any variable costs can be adjusted up or down. I'll say that Maryland has done this for many years, and there are a number of regional plans that worked on this fashion in the 80s as well. So it's kind of a reliable method, but it would require quite a bit of effort in this area. And it's also only really workable if it's done for all hospitals in a region because there are strong incentives to shift patients around if you only apply global budgets to a few hospitals in the area. And that brings me to the conclusions. So I'll go through these really quickly because I think you've heard them over and over. Hospital commercial prices in Monterey far exceed both statewide and Bay Area benchmarks. Prices are not explained by operating costs, labor costs, or quality of care. The high percentage of Medicare and Medi-Cal patients and potentially low margins on physicians and clinics explain a small portion of the high hospital prices. Hospital physician integration, the geographic dominance, and the contracting practices all channel patients to the higher priced hospitals and sustain these high prices. Selective contracting and patient steering, sort of the traditional ways that insurers or payers might control costs, don't really work because all three hospitals appear to be must-haves. Policies that foster competition, like antitrust enforcement, are unlikely to be effective in the short term because these three hospitals are all must-have and have such high prices. And so we would recommend that there be policy options considered that more directly restrain hospital prices. And I believe that's the end. Are we going to take questions first?
Yeah, I should open it up to the board. Questions? Rick? Go ahead, Liz.
Thank you. There's research that shows that hospitals who manage to lower public rates actually are more efficient and commercial. Did you ask at all about just managerial practices, how leadership is actually trying to reduce costs at all? I mean, how much is there a management element?
We asked the question, but I don't think we got an answer that would satisfy you.
Rick, do you have a follow-up?
I'm hoping you can help me understand a little bit more. You showed that was very helpful, and thank you for the report. Thank Paul and all of you for the work. You showed that operating costs per admission aren't higher than Bay Area average. And you showed in the report, I don't think you showed in this presentation, that profit margins are somewhat higher, but not, I think, enough higher to explain the big differences in commercial to Medicare prices that you show. And so I have to think that there's probably some other version of looking at operating costs in which costs actually are higher. And kind of to Elizabeth's last point, maybe these hospitals are not working as hard as they might otherwise to constrain costs. And we heard, eloquent testimony in Monterey about, some of the high cost aspects of some of these hospitals. So I'm wondering a little bit whether the statement operating costs aren't higher, and I know it was supported by that one graph, but I imagine there are probably other graphs that might look at this a little differently that might come to a somewhat different conclusion. Because unless profits are so much higher to explain the high prices, and I don't think they were enough higher to explain the high prices, there's probably some other view of the world in which operating costs do look higher, or at least that's my suspicion, but you're much closer to this than I. So that my question is that completely off base or not?
If I could just add a question onto that, is there another, are there reserves significantly larger? Is that what explains this? I mean, where's the money, I guess?
Yeah, so there are some things we didn't do a deep dive on reserves, but if you look at things like days of cash on hand, just the amount of money in terms of like marketable securities, like stock market type of things, those numbers are above. Like I think the number for days of cash on hand was somewhere around 400 to 500 days on cash on hand. From recall, it's about, I think nationwide, the median is something like 200 days of cash on hand. So along those dimensions, the hospitals in Monterey are higher there. There's nothing, do you want to say any more about that?
So the operating costs that we presented here were based on HCI hospital cost reports. We also did look at health system cost reports, the federal government sort of 990s, et cetera, and what can be labeled a cost in those is much less consistent. And we found it very difficult to look at 3 hospitals and try to analyze the cost reports of the overall system. So what you see here are costs for the hospital, and I think there is reason to suspect that if you could do costs do a deep accounting of the costs behind the 990s of the overall health systems, you might get a different perspective, but I couldn't really comment on what that might be because we were unable to do that because of the differential in the way things are reported at the health system level to the IRS.
Ian?
Yeah, just on that exchange, my takeaway from that, correct me if I'm wrong, is that a hospital with 400 or 500 days of cash in reserve could continue operating the way it is right now without bringing in another penny in revenue for a year and a half. And I haven't heard from anybody else in Monterey County who can do that. And that's without cutting executive pay or what have you. I just want to accentuate how grateful I am for this report. We've heard months and months of heartbreaking testimony from people in Monterey County about not just the damage this does to people's health, but to their ability to survive in that region. And I'm so proud to live in a state that will hear the testimony of food workers and ag workers and teachers and take them seriously, and as seriously as this report shows. I have learned more from this report. None of it surprised me because it just reinforces what so many people have been telling us. But I really want to thank OCA's staff and its partners and CalPERS and Covered California for taking this so seriously and doing such a deep dive. I do want to acknowledge this is just a diagnosis of the problem, and as you've pointed out, this body is limited in the actions it can take to actually make a difference and a dent in the problem. But you know, I think this gives policymakers some a very helpful roadmap as to what happens when a market fails to take care of Californians' needs. You know, I really appreciate you putting on the table for discussion the price regulation and global budgets, as complex as those are. I'm glad they're on the floor for discussion. You know, and I've said again and again that I feel like Monterey County is our state's canary in the coal mine, and it is the extreme of what can happen, I hope. But I think there are lessons for all of California in this. So thank you to everybody here for doing this.
You're here, Elizabeth.
Just briefly, I want to pile on to Ian's comments, but we've also just done an analysis using the HPT and TIC data with claims and quality. So we're happy to share that with you because it shows very specifically where some of the rates vary and how they align to quality, which is not at all. So we'd be happy to share that.
Don, I'm curious, any surprises for you in this
No,
report?
I mean, it's our data, so much appreciated. You know, I will add, you know, we have had a very challenging time even keeping insurance products in Monterey County. So starting January 1st of 2026, we are removing a low-cost HMO product, a Blue Shield Trio product, which we worked very hard to get down there to give provide affordable options for CalPERS members. What we saw in our rates development process this last year for 2026 is that I think, if memory serves, it was going to be a 6% statewide impact for Trio if they stayed in Monterey. So Monterey as a single county was contributing that level of inflation. That puts, when in a environment where we have narrower network plans competing with other narrow network plans, that kind of difference in premium is potentially fatal. So we had to make the very hard decision to remove Trio, replace it with a significantly more expensive product, and it is every year a challenge to keep insurance products down there. And so it's you know, there are challenges in high-cost counties, but there are unique challenges there. It is frustrating. I don't know how this plays out. We are worried about, you know, we have a general mission to make our products available to any public sector entity in California that wants to contract with CalPERS. Too much exposure to Monterey can be devastating for our ability to put an affordable product on the market, not just in Monterey, but statewide.
Anything you wanted to close with before we open it up for the public?
No.
Well, on behalf of the board, let me thank all of you for the research and the data. I think the information that we have heard from all the folks who've traveled here to testify, combined with this empirical research, I think really gives us a compelling need to try to figure out what we do to begin to remedy this problem, because it's quite acute, quite severe. So thank you very much for your research. And now we will take public comment on this item.
All right, we will now take public comment on this agenda item. Please limit your comments to 2 minutes or less. Looking virtually, seeing one hand raised, and those in the room, please step to the podium. Going to our virtual attendee, you should be unmuted on RN Estevan, I believe. Please go ahead.
All right, does that work? Thank you.
Yes.
am I able to show my camera, the camera, or no?
No, you may not.
Oh, okay.
It's not set up to do that. Go ahead.
No worries. All right. Well, my name is Esteban Rodriguez. I've been at the OCA meetings in person. Unfortunately, I wasn't able to do that today, but I was one of the people that testified to get, attention to my county, Monterey County. So I appreciate you guys, everyone at the board, for taking steps into sharing, shedding light into my county, and as you clearly can see on this report, the things that we as Monterey County residents have to deal with uncompetitive prices, and they just kind of could do what they can. But I thank you so much for this. Also appreciate you guys coming down to Seaside, where I'm from, as well, when we did the meeting back in August of last year, I believe. I just wanted to share that appreciation. Super grateful, as you can see that, it's kind of clearly states of the stuff that we were dealing with right now and still dealing with it. And I'm not sure if this is the right place, because I know this is more, I think, about hospitals, but I also want to shed also some light that it's not only the hospitals, but we also have the ambulance company. We only have one ambulance company that has an exclusive contract in Monterey County. Monterey County is also dominated by this one ambulance company, AMR, and they also seem to be using their market power to drive up prices. I was grateful enough to have my union bring me some data on that. Data from my union's health fund, Unite Here Health, shows that in 2025, we have paid average of 3,100 ambulance cost compared to other places that cost 1,700. Just wanted to point that out. I don't know if this is the right place. I just want to say thank you, and I'm sorry for going over the time.
Thank you. To the podium.
Good afternoon, everybody. Cesar Lara was longtime director of the Monterey Bay Central Labor Council and staff at the California Federation of Labor Unions. And this report validates, or resident of Monterey County, this report validates the board strategy. The lower spending targets for high-cost hospitals are a critical first step. To build on this, we must continue to explore all policy options, from spending targets to potential price caps, global pricing budgets, and bring real lasting change. At the end of it, is this study confirms what Monterey County residents have been saying for years now. We pay some of the most and highest hospital prices in the state of California, and therefore the nation. Just for example, in your own report, like you said earlier, your own report, it shows that inpatient pricings are 31% above the Bay Area average. Outpatient prices are 47% than the Bay Area prices, and this is just a clear example. And to the consequences, these inflated hospital prices have a direct and severe impact on communities and working families. Depressed wages, as somebody that has negotiated contracts with employers in the past, as employers or unions negotiate, they move money away from workers' pockets to cover increased prices. They force unions and families to seek healthcare outside of the county for common practices like, childbirth. Like, the first thing my teachers tell their new staff is, you're gonna have a baby, develop a go bag. So when you're gonna have your pregnancy, you drive as far away from Monterey County as possible to have your baby. This places a heavy burden and ongoing, financial burden on every family in Monterey County and every business in Monterey County, and like Ian said, a failed healthcare system.
2 minutes.
And to quote Dr. King, of all forms of injustice, injustice in healthcare is the most shocking and the most inhumane. Thank you. Thank you for coming to Monterey County, and thank you for continuing this fight.
Thank you. Looking virtually, Francisco, go ahead.
Hi, yes, can you hear me?
We can, go ahead.
Yes, thank you. Francisco Rodriguez with the Monterey Bay Central Labor Council. We represent about 80 unions across Monterey County and Santa Cruz County, representing about 30,000 union members. We want to thank the staff and everyone who contributed to this report. And we agree with one of the presenters at the beginning who said, the people in Monterey County are enthusiastic and willing to speak with anyone who will listen to this. And again, thank you for listening to us. Thank you for putting this report together, because it's going to have, or as was said before, it validates what we know. And what we ask is that your next steps be to explore, again, all the policies to bring real and lasting affordability to the working people of Monterey County so that they can access healthcare and also take care of their families. Thank you again and appreciate the time.
Thank you. To the podium.
I'm Ivana Krajinovic with Unite Here Health. I also want to thank the staff and the investigators for this tremendous report that, is a vindication of what we've been saying, what we've been living in Monterey County for the last number of years. It's also nice to see that there was attention paid to more than just hospital prices, but overall the market dominance and how insidious it is. So consider what happens if you need medical attention in Monterey County. If you are lucky enough to have a PCP who can see you, chances are they're part of one of the hospital groups. We wanted to put together a free option for our folks to encourage them to get primary care. We could only find one practice in Salinas that was of size and taking new patients that wasn't attached to the two big chains. Two big hospitals. We couldn't find anything on the peninsula for that. So that's how dominant they are, even in the primary care space. If you go to an urgent care center, those are also owned mostly by the hospitals. Same medical record, they feed you right into their system. For the ER, obviously people are terrified to go. Monterey is the only place in the country where we do not have to educate people about using the ER because our ER usage rates are quite low. People know with a 20% coinsurance that they're going to be facing a bill of thousands of dollars if they go to the ER. So there really are no non-hospital alternatives if you want care. And to ask sort of answer the question before about where's the money, I think the money is going into preserving and extending this monopoly. They are buying up all sorts of things. They are creating, new services to make sure that if you go for care in Monterey County, you have to go into one of the hospital systems. The consequences, I just want to say the report mentioned two important ones, the crushing debt and the little money left for wage increases, but there's a third, and that's something that a worker once told me in Monterey. And when I asked about healthcare and why they weren't accessing care, he said, well, healthcare is something you access when you can't take the pain anymore. So that's the situation we're faced at. I love that there were actually some other policy options included in the report. I'm a fan of percentage Medicare. Indiana and Vermont have both done this, and we should pay attention to that. But the bottom line is that this is a business decision, and these hospitals could tomorrow drop these prices, and we hope that this report nudges them in that direction to do so. Thank you again.
Thank you. Looking virtually, Daniel, go ahead. Daniel, you're unmuted on our end. You might need to unmute on yours. The mic should be in the top right-hand corner. All right, Daniel, we're unable to hear you. We will come back. Going to the podium. Go ahead.
Oh, Katie Bassler, Salinas, Monterey educator and labor leader. I want to thank OCA for listening to the struggles of educators, healthcare workers, ag workers, everyone in Monterey County that has been suffering. Today I stand before you representing 1,000 teachers who could not take the day off. It's right before Thanksgiving break. And they are, they just got the new rates. And the last time I stood before you, I said that our rates were going up 15%. And we have found that the increases annually for our teachers are going to be between $3,800 and $5,200 for family coverage. So starting in December, our educators are going to have a pay cut with very little opportunity for any wage increase going forward. This study, and thank you all so much, describes the financial struggles of workers in Monterey County in a way that makes it clear to everyone who's paying attention that our hospital systems have created an unsustainable healthcare environment. And I want to call out a couple of statements from the report that were significantly impactful. The first is evidence strongly indicates a market structure defined by a profound lack of competition, with market power amplified by significant physician consolidation. And we have been watching this happen over the past 10 years. And the second is the convergence of these factors has created an insulated market environment where high prices can be sustained, adding a significant and ongoing financial burden to the families and employers of Monterey County.
2 minutes.
Monterey County residents are appreciative of all the time that OCA and staff have taken dedicating your studies to our healthcare crisis, and will continue to advocate for accountability of these egregious billing practices in Monterey County because they are hurting families every day. Thank you.
Thank you. Looking back virtually, Daniel, we'll try it again. Go ahead. Daniel, if you look in the top right-hand corner of your screen in Microsoft Teams, you should see a mic button. You'll need to click that so there's no longer an X above it. And if that doesn't work, you might be able to dial in. Or also log out and log back into Teams again. That could be something on the Teams end. All right, we will go back to the podium.
Hi, Kei Yamamoto with CPEN. Appreciate everybody's graces. I'm taking photos. I'm trying to make OCA famous. And at CPEN, we really commend OCA and the board for taking early action to impose a lower target for high-cost hospitals like the ones that are included in this report that are in Monterey, Santa Barbara, and Northern California. The study confirms what people in Monterey know and have clearly stated here, that they're paying more for healthcare than most Californians and more than most Americans. And we're paying more for hospital care that shows up in our premiums and deductibles and co-insurance. And as hospital prices are going up, quality is not improving. Doctors are not getting paid more. Hospital workers are not getting paid more, and people are getting sicker. So really commend the work that OCA is doing today, and hope to continue to do. Thank you.
Thank you. Looking virtually, seeing no hands raised at this time. We will check back on that in a moment. Back to the podium.
Beth Capel, Health Access California. 20% coinsurance on an emergency room visit for a hotel worker? Are you kidding me? It is outrageous that that kind of cost sharing should be imposed on any Californian. We're talking about an utterly unaffordable emergency room visit. We are proud that OCA not only took early action, but has done first in the nation work to set lower cost targets for very, very high cost hospitals. We hope over time it will make a real difference. You are the first in the nation to sort out that we needed a lower growth target for the very highest cost, so we weren't locking in place that high cost base. We recognize that the very important consumer protection, which is foundational to the Knox-Keene Act, that says a hospital must be within 15 miles or 30 minutes, creates the must-have dynamic that you've heard described today. But the answer is not to weaken consumer protections. The answer is to add, as you are doing, affordability targets that make healthcare more affordable across California. People need care and they should be able to get it. Nobody should be paying 20% of an emergency room visit. That's outrageous. Thank you.
Thank you. Looking back virtually, seeing no hands raised, back to the podium.
Ben Johnson with the California Hospital Association, here to express the hospital community's deep disappointment in the report that was discussed today, as it presents carefully curated analyses to support a reductive conclusion with perspectives of the subjects of the study barely noticeable. Monterey County is unique, but not for the singular reason that the report points to. Put simply, Monterey County combines Bay Area costs of living with rural, economic, and healthcare conditions of some of its inland neighbors. And to sustain their workforces, the Monterey hospitals pay a 10% premium on Bay Area wages and benefits, a fact obfuscated in the report since it did not report actual hospital labor expenses on a per worker basis. In reality, the Monterey hospitals collectively have a 77% payer mix, 14 percentage points higher than the Bay Area hospitals when looked at on a utilization basis. What's more, the Monterey hospitals' payment levels for publicly insured patients pale in comparison to their Bay Area neighbors. For Medicare, their payments are over 20% lower. For Medi-Cal, they're an astounding almost 50% lower. And when you put all this together, you're left with Monterey Hospital's inpatient payments being significantly less than their Bay Area peers. And yet, in the report's rush to dismiss cost shifting for theoretical reasons alone, this analysis was not reported and provided. The hospital's efforts to prop up struggling physician market was noted, but similarly pushed aside. And in the end, the report singularly blames a lack of competition in the county, coming to this conclusion based on the fact that local residents visit Monterey hospitals in high proportions, a fact that is true for hospitals across California. The report takes no interest in the fact that Monterey's hospital market is actually towards the bottom of the pack of California counties in its Herfindahl-Hirschman index score, a standard measure for how competitive a market is. And in fact, the best evidence that the report provides is simply that Monterey residents wish to go to their local hospitals and insurers are frustrated at having to provide an adequate network for their local members. Ultimately, this troubling lack of balance and fairness in the report falls far short of the standard. And the subjects of the report were not invited when OCA visited the county to look into the situation back in August of 2024, and were not seriously consulted or listened to in the writing of this report. We ask for a course correction and urge the board and office to take seriously the need to restore confidence that this can be a fair process for the regulated community. Thank you.
Thank you. Looking virtually, Daniel, we see your hand raised. Let's try it this time. All right, Daniel, we are still unable to hear you.
Daniel, are you there?
Again, the mic is in the top right-hand corner. You'll need to unmute on your end. You are unmuted on our end. We'll go ahead to our next virtual attendee, Nahara.
They're texting me saying that it's not ready though. Like it's the mute button's away.
Hello, can you guys hear me?
Sir, do we have?
We can hear you now,
Please.
Nahara. Go ahead.
Hello, everybody. I'm actually speaking. Mr. Dodge is right next to me, and he's having some tech issues, but he is going to jump on my computer where he could say his
thank you.
public comment.
All right.
Mr. Dodge, are you ready? You're over here. You're over here. Go ahead.
Hello, thank you very much for your patience. I appreciate it. I don't know what's wrong with the app on my part. Good afternoon. My name is Danielle Dodge Sr. I am with the American Federation of Teachers, 84 AFT 4400 at Cabrillo College. I'm also with the Monterey Bay Central Labor Council. I want to be able to thank the board for hearing our voices and listening to the voices of working families throughout the Monterey Bay area. It actually gives us hope, and some of the ways of our communicating to government at a time when many people feel their voices aren't heard. We do live in one of the highest areas in the state of California, if not the U.S. And while the numbers might not indicate it for those that don't know, we're the majority of working families in Monterey County, in the Monterey Bay Area. We're a service industries. We're hospitality industries. We're in the agricultural industries. We're teachers and social services. We're what's left of the middle class here in our region and part of California. Hospital costs directly affect our lives, and I really think that I want to be able to commend the board for listening to working families, because these are real people, real lives, generations of families that have lived in our areas, and a community of people that are recently to this country who make up the backbone of the agricultural industry. We have to make real life choices. Do we go to the hospital, or do we save our money to be able to spend it on baby food, diapers, and household needs? I think those are choices that anybody in the great state of California shouldn't be forced to make. So please continue your advocacy. Please continue to be able to address the cost here in Monterey County. We're trying to be able to fight for affordable health care for all of our residents in the Monterey Bay. Thank you very much for allowing me to speak.
Thank you. Looking virtually, Hector, go ahead.
Hello, can you hear me?
We can.
Hello?
Yes, go ahead.
Okay. Hi, my name is Hector Aspilcueta, and I'm the Vice President with Unite Here Local 19. Our members work in different industries, and one of the industries that we represent is the hospitality industry, which are housekeepers, cooks, and servers. And one of the things that we have experienced throughout the years of contract negotiations with the employers in Monterey, it is that our wages continue to drop because we had to sacrifice that in order to pay for expensive healthcare, especially in the Monterey area. I think we know from the work that the OCA board has done how expensive it is for people living in Monterey. Our members are low-paying workers. So I just want to applaud OCA and the board for taking early action to impose a lower target for every high-cost hospitals, like the ones included in Monterey, Santa Cruz, and in Northern California. So I hear what the industry says, the hospitality industry says, but you have to look into the people's lives in Monterey. We are not wealthy people that can afford to go to the hospital when we have to decide whether to pay for our rent or to continue feeding our children or go to the hospital. We have many cases of people not going to the hospital because they can afford it. Thank you very much to OCA and the board for doing the work that you do.
Thank you. That concludes public comment on this item.
Thank you, everybody. Any public comment on any other matter? We will open the floor now.
Great. For the general public comment period, if you'd like to make a comment, please step to the podium or raise your hand virtually. Seeing no virtual hands and no one at the podium.
So let me just close this meeting by really appreciating the OCA staff, who I think has just done a tremendous job on many, many fronts, those that we covered today, and certainly on the issues in Monterey County and all the other efforts that you're underway in implementing new efforts in your department. So thank you. And with that, we stand adjourned.